Hello.
Yes, we are starting.
May I start my presentation, sir?
No, just let me introduce our esteemed evaluator and chairperson.
Okay.
Okay.
Good morning, prestigious guests and participants. Welcome to the International Conference on Recent Innovation in Biomedical Sciences and Healthcare for Sustainable Development at Galgotias University on the theme of Biomedical Sciences and Engineering, Medical Biotechnology, Clinical Nutrition, Dietetics, and Forensic Sciences. This event is proudly sponsored by Biopractify Private and Limited and PhysioBiome experts, supported by Anushadhan National Research Foundation, Department of Science and Technology, Government of India, and organized by School of Biomedical Sciences, Institute Innovation Council, IQAC, and GIC RISE, Calcutta University, India. We are thrilled to have you here and look forward to an engaging and inspiring event. I'm honored to welcome you today to this prestigious event. I am Khushi Kumari and I will be serving as a host for today. It is my pleasure to introduce my esteemed co-hosts, Ayushi Chaube and Jyoti, who have been helpful in organizing this conference. Together, we aim to make this event both enlightening and impactful. It is with great respect that I'm inviting Dr. Gaurav Kumar Sir, ISC Head, Associate Professor, and Convener of this conference, to tell a few words about this conference and to provide insights and innovation or internship.
Thank you, Khushi, for the invitation. Am I audible? Shanti?
Yes, sir.
Okay.
Yes, sir.
Okay. Okay. So good morning, everyone. A very warm welcome to all of you for this international conference that will be held from 2nd, 3rd, and 4th of September in this year. So this 3-day event is proudly hosted by the School of Biomedical Sciences, as Khushi has discussed, and we get a support from DST, Anusandhan National Research Foundation, Government of India, to organize this conference. We are very thankful to the Government of India for this support. So this conference serves as a premier platform for the scholar, researcher, and practitioner from around the world to discuss and explore the latest advancement and pressing challenge in biomedical science and healthcare. Our goal is to contribute meaningfully to the discourse on achieving sustainable development goal within these fields. So we are honored to have 25 esteemed speakers from both national and international institutions. Our international speakers come from Germany, the United States, Nigeria, Brazil, and Sweden. So these experts will share their valuable insight and experience, reflecting the global nature of innovation in biomedical sciences and healthcare. Our national speaker represent from the prestigious institutions such as Banaras Hindu University, IIT BHU, Motilal Nehru National Institute of Technology, Allahabad, Deenbandhu Chotu Ram University of Science and Technology, Sonipat, National Institute of Technology, Raipur, Jamia Hamdard, Delhi, Northeastern Hill University, Shillong, Naipar, Ahmedabad, and Bundelkhand University, Jhansi. So we are pleased to report that the conference has attracted a remarkable more than 200 participants from 28 different institutes, reflecting the strong interest and enthusiasm for this event. We have 38 participants scheduled to give the oral presentation and 45 participants presenting the poster. So today, the conference begins in an online mode, and over the next 2 years, it will be transitioned to an offline format, allowing for more dynamic interaction and discussion for the participant with the speaker. So we are fortunate to have approximately 10 esteemed speakers chairing the session for both oral and poster presentation on this day, and also they will be evaluating the participant contribution in their research area. The conference will focus on 4 major themes like biomedical sciences, medical biotechnology, nutrition and dietetics, and forensic science. So we are excited to recognize the excellence in this field through the several awards, including 9 Best Oral Presentation Award, 9 Best Poster Presentation Award, an award for the best interactive participant, the participant who will having the maximum interaction, we will facilitate them, 2 Lifetime Achievement Award, 2 Best Researcher Award, 3 Young Researcher Award, and the Outstanding Social Worker Award, as well as Outstanding Alumni Entrepreneur Award from our school. So I am confident that over the next 3 years, we will witness inspiring discussion, groundbreaking research, and fruitful collaboration. Let us make the most of this opportunity to learn, share, and innovate for the healthier and more sustainable future. So once again, thank you all, and I wish you a very productive and enriching conference to you. Thank you, Khushi, for providing the opportunity. Over to you.
Thank you, sir, for the information, and your contribution and insight have been essential in shaping this event. Now, I would like to invite respected Professor Ranjana Patnaik, ma'am, Dean School of Biomedical Sciences and General Chairperson of this conference, to say some motivational word. Please, ma'am.
Thank you very much, Ayushi. Good morning, ladies and gentlemen, esteemed colleagues, distinguished guests, and dear students. I am truly honored to welcome you all to this conference, that is IC BSH 2024, that is International Conference on Recent Innovations in Biomedical Sciences and Healthcare for Sustainable Development. As we gather here today, we find ourselves at a pivotal moment in this field of biomedical sciences and healthcare. The challenge we face are complex, yet they are also ripe with opportunity. This conference provides us with a unique platform to engage in meaningful dialogues, share innovative ideas, and collaborate across disciplines. Together, we can explore new horizons and forge pathways that will shape the future of relevant of this field. I would like to take a moment to acknowledge the hard work and dedication of everyone involved in this or in organizing this event, from our staff to our volunteers. Your commitment has made this gathering possible, and we are grateful for your efforts. So thank you very much. I think we should start with the session.
Thank you, ma'am, for addressing the participant with a motivational word. At this time, I would like to introduce our esteemed session chairs and evaluators who will be providing their expert assessment of today's presentation. Now, please join me in extending a warm welcome to Dr. Yuvinesh, our esteemed session chair. Dr. Yuvinesh is an assistant professor at Motilal Nehru National Institute of Technology, Allahabad. He has been recognized with prestigious awards, including the DST Serb National Postdoctoral Fellowship and the Siddharth Bialak Gandhian Young Technological Innovation Award. With a strong background in bioinstrumentation, bioelectric devices, and AL/ML in biomedical processing, he has published 41 articles and holds multiple patents. Thank you for your presence, sir. Our next session chair, Dr. Abhimanyu Thakur. Dr. Thakur is a neurosurgery scientist at Harvard Medical School and General Hospital. Dr. Thakur earned his PhD in biomedical sciences from the City University of Hong Kong, where he conducted groundbreaking research on biomarkers. He has contributed significantly to regenerative medicine and stem cells research. and publishing in top-tier journals like Science Advances and Nature Communication. Dr. Thakur also holds 5 US patents and is an expert in extracellular vesicles. We are honored to have him with us today. Thank you for your presence, sir. Now, with our introduction concluded, we are ready to commence with the presentation. We have a diverse and compelling series of presentation. We look forward to valuable insight each presentation will offer. Let us proceed. Let's call out our first presenter, Shanti Priya. Please start with your presentation.
Yes, ma'am. I'm going to share my PPT now. Is it visible, ma'am, my PPT?
Yes, not yet.
Not it?
No. So you have to reshare your screen.
1 second, sir.
The house
So you are the co-host, so you can share your screen. And you have
Yes, sir. I have shared
8
it.
minutes for the discussion, for the presentation.
Sir, I have shared my screen. Can you visualize it now? Hello, sir.
Is there any trouble, Shanti?
Sir, I have shared it, but you are not able to see it. I do not know what is the reason.
Yeah, we can just
1
hear your
second.
voice. So I think you need to reshare.
1 second. 1 second. I
Thank
will
you.
share my screen, sir. Can you see it now, sir?
No, we
Shanti
can't.
Priya, are you audible?
Yes, sir. I'm audible. I have shared the screen and the PPT is, I can see this PPT, but are you able to see it? Hello? Hello?
Gaurav sir, or else you collect the PPT via mail and you can share it. It will be best. If she is facing some problem, we can't able to see, right?
Sir? So I have given the share option and document also.
I guess Shanti Priya is
Screen.
having some trouble. Let's call out next presenter, Rinku Kalra. Please start with your presentation.
Good morning, everybody. Good morning, respected judges, respected seniors, and my dear colleagues. I'm just sharing my screen.
Rinku Kalra,
Yes, sir.
Shanti Priya has shared.
I have shared it, sir. Is it possible?
Okay.
Is it seen, sir? Gaurav, sir. Good morning, sir. Can you see my presentation?
Yes, you go ahead with your presentation, ma'am.
Okay, thank you, sir. Thank you so much. So I'm Dr. Rinku Kalra, PhD scholar at Galgotias University. And today I'm here to present my study, which is a randomized controlled clinical study, which is basically on comparative evaluation of clonidine and dexamethasone used as additives to lignocaine for pterygomandibular nerve blocks. I'll be presenting under the following headings. So lignocaine in dentistry, as we all know, is a gold standard, be it with vasoconstrictor or without a vasoconstrictor. And adrenaline is the most common vasoconstrictor used. And why do we use vasoconstrictor with lignocaine? Because of vasodilatory inherent vasodilatory properties of lignocaine. We need to achieve hemostasis in the site of surgery. Also to slow down the absorption of lignocaine from the site so that duration is increased and depth of anesthesia is increased. However, adrenaline has a flip side that it causes burning sensation because of lower pH as compared to plain lignocaine. It also gives systemic side effects like on cardiovascular and CNS. It cannot be used when certain drugs like tricyclic antidepressants are used or MAO inhibitors are used, and it cannot be used in end organs. So a variety of other molecules have been tried and also tested and documented in the medical literature for the various regional and local nerve blocks. However, today we'll be discussing dexamethasone and clonidine. But why do we have to use additives with local anesthetics? So as to increase the depth of anesthesia, to increase the duration of anesthesia, to achieve a faster onset, also to have better postoperative pain control and minimize blood loss. So these publications have been already done, wherein 2% lignocaine with clonidine admixture was compared with the gold standard adrenaline lignocaine formulation, and dexamethasone was compared with the gold standard adrenaline previously. So today we are discussing a new study which compares both clonidine and dexamethasone now. So clonidine, as we know, is a partial alpha-2 agonist, has been clinically used as an antihypertensive agent and also has a mild sedative effect. It has direct action on the peripheral nerves by secretion of enkephalin-like substances. It is also a vasoconstrictor. It works directly on potassium channels and causes hyperpolarization. And it also has a centrally mediated analgesic action, which helps in postoperative period. Dexamethasone is a known synthetic steroid and it has a multimodal anti-inflammatory effect. It also works on C fibers, potassium channels, basically. It also has a vasoconstrictive property as reported by Marks and Barlow. Now, the aim of the study was to compare both 2% lignocaine with clonidine and dexamethasone with 2% lignocaine for vasoconstrictive effects, quality of anesthesia, and pain control. Now, quality of anesthesia was described in three particular parameters like onset, duration, depth of anesthesia. Vasoconstrictive effects were determined by the amount of blood loss, and pain control by the amount of analgesics consumed in the postoperative period for the 3 days postoperatively. Also checked were any other local or systemic side effects. So this was my research question. Going to materials and methods. The study was conducted with all due ethical clearances in the Department of Oral and Maxillofacial Surgery. And this was a double-blinded study because observer and subject both were blinded. 18 to 45-year-old adult patients who reported for surgical extraction of impacted mandibular third molars were included in the study. The sample size calculated was 40 subjects per group. Now, all the healthy patients were only selected for this study because the ethics committee did not give us clearance to evaluate on patients with medically compromising conditions. 18 to 45 years was the age group selected, and we selected only third molars which belong to Peterson's difficulty index of moderate, that is 5 to 7. This was a randomized control trial, so 18 subjects were randomly selected who met the inclusion criteria, divided into 2 groups. We used freshly prepared solution of 2% lignocaine with 1 ml of clonidine, so 3 ml, and again 2% lignocaine 2 ml with 1 ml of dexamethasone in group 2. The solutions were freshly prepared, however, and allocation criteria were followed, and the subjects were blinded, observer was blinded. Consents were taken from the patient. This is the moderately difficult case as per Peterson's difficulty index, as you can see on the OPG. This was the pterygomandibular nerve block used, and that was the surgical procedure. Now, onset was measured from the time of injection to the first tingling numbness sensation felt on the lower lip. And duration of anesthesia was onset of tingling numbness to the first rescue analgesic taken by the patient. Depth was evaluated by the VAS score, VAS scale as depicted below. And that was an intraoperative experience of pain by the patient. blood loss was calculated by suction jar method and gauze piece method, and post-operative pain control by the amount of analgesics consumed. Now, in all the subjects, we had prescribed diclofenac potassium, which was 50 milligrams 3 times a day, but the number of analgesics taken were charted. Now, statistical methods were used to check whether the data followed a normal curve by Shapiro-Wilk test, and it was seen that only onset followed a normal curve, and hence t-test was used on onset, and the rest of the other parameters we used Mann-Whitney U-test. My results in discussion were as follows. Demographically, both the groups were similar and matched based on the age criteria and the gender. So there was no statistically significant difference in both these parameters. The groups were similar. Onset by t-test showed a very, very high statistically significant difference between the two groups, with onset being faster in the dexamethasone group as compared to the clonidine group. The duration of anesthesia was higher again in the dexamethasone group, and that was statistically significant. Number of analgesics consumed by the dexamethasone patients was comparatively less, again statistically significant. There was, however, no statistically significant difference for the number of injections used or for the depth of anesthesia and the amount of blood lost. So, so as to determine that the vasoconstrictive effect of more or less same between clonidine and dexamethasone, and depth of anesthesia was also almost equal. All these studies, which were conducted to compare clonidine and dexamethasone on the various other nerve blocks, suggested the first study by Hemlata only suggested that the molecules were comparable. There were no broader differences and statistically significant differences. However, the remaining 3 studies did say that there was a difference in onset, duration, and post-operative pain control. None of these studies assessed the amount of blood lost, and none of the dental studies have till date documented this difference with the comparison between clonidine and dexamethasone. So to conclude, dexamethasone as an additive to lignocaine was better molecule because it showed a faster onset, prolonged anesthesia duration, better post-operative pain control as compared to clonidine, and these differences were statistically very, very significant. However, not much of a difference, because for onset, as we saw, there was hardly a 20-30 seconds difference, and for pain control the scores were similar. For the post-operative analgesics, there was just difference of 1 tablet, and duration wise 15 to 20 minutes duration was achieved more than clonidine in the dexamethasone group. So this study can now be extended to other medically compromised patients based on the ethical clearances, and also for other orofacial nerve blocks. These are my references. Thank you so much.
Thank you, Rinku Kalra,
Thank you, sir.
for the nice presentation. Now, I would like to invite Abhimanyu sir and Yuvnesh sir for the question answer session.
I think if Dr. Avnes wants to go forward.
No,
Hello?
sir, no, sir. You just continue. I will follow with it.
I see. Okay. Yeah, I think the overall presentation was good. I think had it been much better if the references which have been chosen, I think it's better to choose some of the authentic source, and also the paper quality which you have chosen for the references, those are not good enough. Those are not good enough to establish whatever you have put in the presentation.
Okay, sir.
Yeah, yeah. I think overall it's fine. Yeah. Thank you.
Thank you, sir. Thank you.
So actually, I had the same status of mind. Actually, the idea from where you have taken, right, the base, it was like Bangladeshi journal and these things, which sometimes it is like it can be true or sometimes it can't be. So it's up to you.
Right.
But we recommend you to go with something like new, old established and reputed journals. Old, the word old you need to remember, because they are highly good journals out there. You just go with that. But you have done a nice work, and you are just compared two different drugs, right?
Yes, sir.
It was good, and actually, I believe you will furnish it flying colors in future.
Thank you, sir.
So
Thank you.
go ahead. Is there anyone to ask any question technically from audience side? So no one is ready to. No one is there, I believe. So everyone is okay with
Sir,
that.
I have granted the permission to audience if
Okay.
they can unmute themselves to ask question.
Okay, fine. Rinkuji, can you please suggest something like
Yes, sir.
summary in a word, in a line?
Mm-hmm.
So how, what you are exactly means, what is your observation from this?
So,
Because it's look good actually.
yes, sir.
Generally we use Dexter, right?
Yes,
For
sir.
everything. For if we have anything, if we go to the hospital, they used to give us the Dexter.
So basically, this is a part of my PhD thesis, a part of my research project for
Okay.
PhD, wherein I have compared 6 groups. I've used 4 groups and compared with the gold standard LA, lignocaine plain and lignocaine with adrenaline. So, like I had showed you, 2 of my previously published studies where, individually these drugs were compared with adrenaline. So then I thought of comparing these drugs together. Between the drugs, how things work. The other drugs which were used were potassium chloride. So I used representations from each group, one alpha 2 agonist and one salt like potassium chloride. I also used one phenyramine maleate. So all these drugs were used as part of my big PhD project, but individually for publication, I have now, segregated them, and then I will be, of course, doing a major publication on that. Uh,
Uh,
as you rightly pointed out, the journals which I've used as references were not so good journals, but sir, there is really a dearth of such studies because for years altogether, only adrenaline has been taken as a gold standard. Now, my focus was also on the major project. It was also hemodynamic variables, which I have not used in this particular study because clonidine, as we all know, is an antihypertensive agent. So obviously, blood pressure is going to fall down. And that was not a assessing parameter presented here. And dexamethasone obviously will not have any effect on the blood pressure. So there was no point in projecting that particular parameter here. But when I compare it with adrenaline, yes, hemodynamically, clonidine was a better molecule because it gave a hemodynamic stability. And, for medically compromised patients, this is also a very good option as compared to adrenaline. Now, what happens is post-COVID period, we have seen there are, a lot of, like I'm a surgeon, so in my private practice, all these patients who were not a known hypertensive or not known diabetic earlier have come up with these complications. So, blindly using adrenaline in such patients is not a very good idea, I feel. So we should come up with some molecule which can serve as a replacement to adrenaline and, get a patent rather than having lignocaine with adrenaline all the time. Let's have some molecule which can, replace adrenaline and give us better results, especially in a medically compromised issue.
exactly. Whatever you said, it was looking good, and it will be good actually. But
Yes,
the thing is that you need to summarize everything and go for a good publication. When there is a
yes,
lack of publication in this area, you
yes.
need to target an higher journal. Okay.
Yes, sir. Yes, sir. For my own publication now, henceforth, I'll be doing it in a better journal. My
No,
two
that's
other publications were in Scopus Index journal, sir. One was Contemporary Clinical Dentistry. One was a Journal of Oral Maxillofacial Surgery from France. So, for potassium chloride, I have done it in that journal. I have not shown it because this was out of purview of the topic potassium chloride. So that is how, I've just taken a part because 8 minutes doesn't do very much big justice to the whole thing. That is why.
okay. Okay. Thanks a lot. Thanks.
Thank you, sir. Thank you so much.
I hope all the doubts and questions are clear. Now let's proceed with next presentation. Now our next presenter, Shanti Priya, please start with the presentation.
Yeah, okay.
Happy morning. Happy morning, everyone. Am I audible?
Yes, yes, yes. You go ahead.
Yeah.
Can you see my screen, sir?
Yes, yes, yes. Go ahead, ma'am.
Okay, sir. So I'm glad to present my scientific paper presentation in this prestigious international conference, sir. So that my topic of the presentation is effectiveness of home-based walking exercise program on maximum pain-free walking distance among patients with peripheral arterial disease in a selected hospital, Coimbatore. So the peripheral arterial disease actually caused by poor circulation in the lower extremities. The common cause is atherosclerosis. Because of the atherosclerosis, the lower extremities will not get sufficient blood circulation. So this condition is commonly diagnosed by measuring the ankle brachial pressure index. If the ABI is less than 0.9, is considered as a diagnosis of peripheral arterial disease. So usually this PAD is termed as silent killer because 60% of the people who have experienced it will not have any symptoms at all. Whether the patient has symptoms or not, PAD is an indicator of diffuse and significant arterial disease elsewhere in the body. So patient is at an increased risk of mortality, myocardial infarction, and stroke. So here intermittent claudication is very, very important thing, because it causes reproducible lower extremity muscular pain induced by exercise and relieved by rest. Superficial femoral and popliteal arteries are most commonly affected by atherosclerotic plaque. Can you hear me, sir? The objectives of the studies are to assess the maximum pain-free walking distance among patients with peripheral arterial disease in experimental and control group, to evaluate the effectiveness of home-based walking exercise program on maximum pain-free walking distance among patients with peripheral arterial disease in experimental group, to compare the maximum pain-free walking distance among patients with peripheral arterial disease in experimental and control group. So the hypothesis, I have formulated null hypothesis. There is no significant difference in maximum pain-free walking distance in patients with peripheral arterial disease after a home-based walking exercise program. So the assumptions are the patients with PAD may have reduced maximum pain-free walking distance. Home-based walking exercise program will be an effective method in improving pain-free walking distance in patients with PAD. The delimitations of the studies are: the subject of the study will be PAD patients in the age group of more than 40 years. PAD patients, those who are present at the period of data collection. So can you hear me?
Yes, yes, ma'am. Go ahead.
Yeah, we can hear you, but your slides are not moving. It's not coherent with your talk.
Oh, yes. Actually, I have shared the slide also, but something is okay.
It's fine. It's fine. Go ahead. Go ahead.
Madam, just ask the organizer to move on with the slide whenever it is near. You can tell next slide, please. It's simple.
Okay. So I would like to know whether the organizers are operating my slides or not, because I have
Operating. They are operating.
share my slides with them, sir. Okay. So next I'm moving with the methodology. So I have used quantitative research approach and research design. I have used quasi-experimental pre-test, post-test control group design. Group and control group, I have given test. So I have used ankle brachial index as well as 6-minute walk test as outcome measures, and experimental group received home-based walking exercise program, and the control group received routine care. So after 12 weeks of home exercise program, I have done posters with the same outcome measures like ABA index and a 6-minute walk test. So the variables, the independent variable is home-based walking exercise program, and the dependent variable is maximum pain-free walking distance, and extraneous variable, that is medication consumed for PAD, and influencing variables are age, sex, body mass index, and duration of PAD. Then about the setting, so I have collected samples from KG Hospital, Coimbatore. This is a 550-bedded multi-specialty hospital. I have used purposive sampling technique as a sampling technique. Then sampling criteria, the inclusion criteria is a PAD patients aged between 40 to 65 years with intermittent claudication pain at Fontaine stage 2A and 2B, and unilateral peripheral artery occlusion, willing to participate in the study, who are able to adhere and cooperate the instruction. Exclusion criteria are PAD patients with history of exertional angina, exercise tolerance limited by leg pain due to non-vascular origin, myocardial infarction within the preceding 3 months, surgery related to PAD during the preceding 3 months, and lower extremity ulcers. Data collection tools. So I have included 4 sections in this. Section A for demographic data, section B ankle brachial index, section C 6-minute walk test to assess the maximum pain-free walking distance, and section D for description of intervention. So in the description of intervention, you actually the PAD patients, since they are having claudication pain, initially after this warm up and cool down exercises are demonstrated to the patient, and after the warm-up exercises, initially they will do 5 minutes of walking session and 5 minutes of cool-down session. And at the end of 8th week, they are able to do 40 minutes of walking with 5 minutes of warm-up and 5 minutes of cool-down exercises. And validity and reliability also obtained, and ethical clearance also obtained from the institutional ethical committee. And informed consent was obtained from PAD patients who are participating in the study. And pilot study, a total of 6 samples were selected, and the feasibility and practicability of the tool were assessed, and the tool was proceeded for the main study. And the data collection, the permission was obtained from the CEO of hospital, head of the Department of Cardiology. 20 samples were selected by purposive sampling technique, and 10 in an experimental group and 10 in control group. All the samples were assessed for severity of PAD by measuring the ABI. Maximum pain-free walking distance were measured by 6-minute walk test as a pre-test. The control group received only the routine care, whereas the experimental group received home-based walking exercise program for 12 weeks. ABI and maximum pain-free walking distance were measured in both experimental and control group as a post-test. With the help of PAD t-test and independent t-test and descriptive statistic, I have done the analysis. This is the analysis part. So in this table 4.1 shows the frequency and percentage distribution of demographic variables of PAD patients in control and experimental group. And maximum percentage of the samples belongs to 61 to 65 years of age group, and the maximum percentage of the samples in both the groups belongs to male. And type of family, maximum percentage of the samples are in nuclear family. So am I audible?
Yes.
Am I audible, sir? Okay.
Yeah.
The education status, majority of the majority of
It
the
is
samples
better
completed
if you
school
go
level
with
of
the
education in
results.
both the groups.
Ma'am, sorry, because we have quite less time, right? You go with the
Yes,
results.
sir. Yes, sir.
Go further,
Yes, sir.
go further.
So the
Slides
ankle
can be
brachial
moved
index
further. Go
can
with
you
the
see
results, actual results
the
part.
ankle brachial index? Okay, sir. So the in the ankle brachial index of both the groups shows that the calculated value is more than the table value. So the null hypothesis is rejected. It shows us a home-based walking exercise program is effective in improving the ankle brachial index in both the groups. And the mean values are increasing in the posters, especially it is higher in the experimental group. And the maximum pain-free walking distance also, the table value is 2.262. The calculated values are more than table value in experimental group. It shows that home-based walking exercise program is effective. And the independent t-test also shows that only in ABA there is a the calculated value is more than the table value, but in 6-minute walk test, the maximum pain-free walking distance, the score is less. So the null hypothesis is accepted. There is the home-based walking exercise program is not effective in improving the maximum pain-free walking distance. The limitations of the studies are very small size based on the low outpatient census during the period of study. There is a difficulty with the participants, those who are illiterate. They are not clearly understood the clear pathology of the disease and exercise effect. Many participants were prone to peripheral arterial surgery for immediate pain relief because some patients may have poor pain tolerance, and patients with risk factors like diabetes and hypertension also included in the study. The recommendations of the studies are large sample size can be taken to generalize the finding. The study can be done with bilateral PAD patients to assess the degree of difficulty. The study could be segregated with either superficial femoral or popliteal artery occlusion to assess the percentage of the artery occlusion. PAD-related risk factor modification program can be added as a preventive measures. In future, we can correlate the different age group of patients with PAD. In this study, the intermediate test values are not included for statistical analysis. We can include the intermediate test for statistical analysis. So I conclude
Sorry
there
to
was a
disturb.
statistically
Shanti
significant
Priya,
improvement in
please,
APA. No
please
significant.
conclude.
Yes, sir.
You have exceeded your time. Okay.
So there is no significant difference in maximum pain-free walking distance in 6-minute walk test among patients with PAD following home-based walking exercise program. These are all my references. Thank you very much for the chance. Sir, I have concluded.
Fine. Abhimanyu sir, wish to ask.
Hello.
Hello. So yeah, you were saying something. Yeah. Go ahead.
Sir, you wish to ask something?
Okay, yeah, I think what's your name? Edwina, no? Edwina. So Edwina, yeah, nice presentation. So I would like to know, have you considered about the neuropathic pain? Because sometime due to the oncogenic this drug, most of the cancer related drugs, they induce neuropathic pain. So have you considered that aspect like in your this grip strength test, and what will be the secondary outcome, and what kind of statistical measurement you gonna use here? And how did you
So I didn't
decide
choose
about your
this.
number of, how did you like how did you decide about your sample size here?
So based on the prevalence, I have chosen the sample size as small size because the patients with claudication pain, only less number of samples are coming. So,
will it
based on the prevalence
is
rate, I have chosen the sample size as 20.
I see. So is it more like
Yes,
a
sir.
meta-analysis
And
kind of
neuropathic pain,
thing, or
I
what?
have
Yeah,
it's
yeah,
like
go ahead. Yeah.
actually it's like a clinical trial, sir. Yes. So here mainly I could follow up the patients for 12 weeks period. So I feel that so that may be the reason the maximum pain-free walking distance is not increased. Suppose if the home-based walking exercise program is continued for more than 12 weeks period, sometimes there may be a increase in the maximum pain-free walking distance. So I didn't the neuropathic pain and all not included in the studies. So only the patients with claudication pain. So I have used Edinburgh claudication questionnaire to find out only the patient has claudication pain or not.
Okay, thank you. Thank you.
Ma'am, actually, I have few concerns. Like,
Yes, sir.
have you considered weight of the patient? Based on the age, you have segregated the what you got the groups. But have you considered the weight? Because everyone's weight won't be similar.
Yes, sir. But I have calculated the BMI. So in the BMI, even the maximum samples are having optimal weight, normal weights. Them also they are having the peripheral arterial disease, claudication pain. So they have come with fall under the category of Fontaine 2 and 2A, so 2A and 2B. So
Sorry. It is like
So-
based on the BMI,
so
you have
this home-
calculated, you have segregated the samples, right?
Yes, BMI also on only the demographic variable, but I couldn't get the homogeneous sample uh, because of the limited number of samples are getting, so I couldn't do the homogeneous sampling on the basis of BMI, sir.
Actually, what I suggest is that you better choose the parameter based on the availability. Generally, we do such things. If the sample is
Okay, sir.
limited, you need to discrete in such a way that you get a proper result. From the slides, it is from your presentation. What I feel is that might be your sample. You have limited sample as you are telling, and demographic. Actually, it is like if you are forcing the people to walk for 6 minutes, somebody will walk faster, somebody will walk ultra slow. Getting my point? So with the BMI, you need to
Yes,
calculate
sir.
how the person's behavior changes you have not taken into account as far as I see. So you just concentrate on that because these are the key parameters
Okay, sir.
which definitely will show up some certain results. All the best.
Yes, sir. Definitely, sir. Thank you, sir.
I hope all the doubts and questions were clear. Now let's proceed with the next presentation. Our next presenter is Edwina Raj. Please start with the presentation.
Good morning, everyone. Good morning, respected judges. I'll be sharing my screen. Sorry, 1 minute. Is my screen visible?
Yes, it is visible.
Okay. Can I begin?
Yeah, definitely. Please.
Good morning once again. My topic is about a review on the reliability of hand grip strength, which is used as a nutrition screening tool in cancer patients. I'm Edwina Raj. I'm a registered dietitian at Aster CMI Hospital, Bengaluru, Karnataka, and a PhD scholar from Quantum University, Roorkee, India. To just give a brief introduction about hand grip strength, which is used as an effective tool as a functional test for assessing the patients about their strength as well as their functional status. Hand grip strength, it provides us a roadmap to develop strategies to improve the muscle mass and to test the effectiveness of the intervention of nutrition, what we do among cancer patients. So background is to understand and test the reliability, whether we can use hand grip strength among cancer patients to predict the malnutrition, because malnutrition and sarcopenia is one of the main features cancer cachexia in these patients. So we see a lot of muscle loss as well as the different changes in the muscle strength and the impact and the negativity and the negative impact of the treatment, or we can assess how effective is the nutrition intervention through this as an alternative method. So in this review paper, I've done a review of literature about the 18 studies which were available through all the reliable research portal through Google Scholar. I've searched through PubMed, Elsevier, and BMC, and then EJCN, BMJ, National Cancer Institute, and then NDPI, and so on. So this is the hand grip dynamometer. So in this review paper, among the 18 research studies that were analyzed, 2 research studies were from India, which presented a low muscle strength among breast cancer and lung cancer patients. In that, 13 studies involved large participants, and the studies, they strongly recommend and validate the use of hand grip strength among cancer patients. In these 3 studies, tested the use of hand grip strength among cancer patients, and they concluded that a low hand grip strength is one of the indicators for predicting the prognosis and mortality among these cancer patients who are undergoing the treatment. But only one study conducted among 63 participants in Japan who were on lenvatinib. This is one of the drug used to shrink the tumor. So in these patients, especially who are on unresected hepatocellular carcinoma, it depicted that decreased hand grip strength was a poor prognostic factor among these patients. So because the drug itself has a side effect about the muscle loss, which cannot be used in these patients. But otherwise, in all other patients, cancer patients, hand grip strength can be used as one of the reliable tool in assessing the muscle mass and strength. So hand grip strength is a simple, non-invasive, feasible technique that indicates prognosis, mortality, and a predictor of post-surgical complication, especially during the treatment of cancer. It provides a roadmap to all the practicing clinical dietitians to develop strategies to understand the muscle, to improve the muscle mass through nutrition intervention and test the effectiveness, especially among the cancer patients. So these are some of my references. Thank you so much for your patient hearing. I'm open for questions. Am I audible?
Yes, thank you for sharing your extensive expertise, and we can now begin the Q&A session.
Thank you, ma'am.
So I think one thing I would like to understand how this work is related with the conference goal, because one of the criteria is like to evaluate this. It should be relevant with this conference goal. So how is it relevant with this sustainable development?
Sir, one of the topics that was asked for me is in the conference was focused on clinical nutrition and dietetics. So as part of that, I have picked up this topic. So this is one of my research topics, using hand grip dynamometer. So that is why I've presented this.
Yeah, I think I appreciate what you are saying, but I think in general, I mean we should always talk scientifically about like the questions, So when we are asking about why it is relevant with the sustainable development, so I think at least you can talk something like how this study is has how this relevant, how this study is like, does it make sense with the sustainable development? How it has certain point to be make sure like it has some sustainability in future. Yeah, something like that, I mean, you were
Yes, sir.
saying like, because you
I
just chose one of the keywords, yeah. But just I'm just trying to make one point that we should, our answer should not be that our guide has given this or someone has done this or
No, sir, I understand your
the
point.
keyword yeah. Yeah, that
I
is there,
get your
yeah.
point.
Okay, yeah. Overall,
Yes,
it's good. And also your slides, most of the presenters, like those who have presented so far, the slides are too messy, so many words. I think it should be
yes, sir.
simplified and
Okay, sir.
less word, more pictorial diagram, more flowchart. Because when you go to some international forum,
Correct,
these
sir.
things like these things should represent, what you have acquired, Yeah,
Right,
I think
right, sir.
overall it seems fine because this is something like one of the many project like what we have been doing even in masters or something. Yeah, but it's good. Yeah, thank you.
Thank you so much, sir.
Edwin or Raj?
Yes, sir.
Actually, the thing is that you are considered only hand movement, grip movement, right? Why you have not considered the things like patient who, for example, whose breast has been removed, they had a pain while they like we used to do, right? Exercise, like,
Mhm.
hands up, we used to say.
Mhm.
When they take up the hand, they used to get the pain. Why you have not considered that exercise? Only grip. Is there something else? Something key point?
Sir, upper body muscles is more correlated with the protein intake. That is what most of the studies depict. And not just protein intake, what matters is their physical activities, resistance, exercise also. The ones who do not exercise and do not take adequate protein, it impacts their upper body muscle. So that's the reason it is one of the easy and a simple way to assess. It is non-invasive, especially in a clinical setting. It is very quick and we can understand whether any further analysis of body composition to check muscle mass is needed or not. This is one of the simple tools, sir, that can be used in all the OPDs by clinical dietitians. That is what I found in the studies.
Fine, but actually I have seen people who struggle to move the hand further towards their head,
Right,
over
sir.
their head. Getting my point?
Yes, sir, I understand.
So actually, being the patient who, for example, who was like went to this money operation struggle,
Correct.
radiation, etc., etc. Okay,
So
fine.
whether the intervention is really impacting them or they're deteriorating is something that we can understand in a simple way. That's all, sir.
Okay, fine.
Yeah.
Okay, a lot need to be done, right?
Yes, sir. Yes, sir. Thank
Okay,
you
go
so
ahead.
much, sir.
Thank you. We can go with the next presentation.
I hope all the doubts and questions are clear. Now let's proceed with the next presentation. Mr. Suresh Kashinath Ghatge, please share your presentation. Mr. Suresh, your screen is visible. Please share the presentation.
Is it visible, ma'am?
Yes, it is visible.
I'm Advocate S.K. Ghadge from Galgotias University.
Mr. Suresh, the presentation is not visible. It's showing the Zoom meeting.
Oh,
Please try to reshare the screen.
is it visible?
Still, the presentation is not visible. Please try to reshare the screen.
I'm not techno savvy, so I'm finding difficulty. I'm sorry.
Please go back to the Zoom meeting and end the sharing, then try it again.
Yeah, yeah. Can you see my screen?
Mr. Suresh, the screen is visible. Please tap on the presentation at the bottom.
I hope now it is visible.
Yes, it is visible now. Thank you.
I'm Advocate S.K. Ghadge from Galgotias University, Liberal Education, working under Professor Dr. Anuradha Parasar. My topic is nursing healthcare in rural India during and after COVID-19, a study. The health sector is one of the most significant sectors in India, where nurses are one of the main pillars that provide the best treatment to patient. This paper discusses the nursing condition in rural India during COVID-19 and the situation after COVID-19. The main focus of this paper is to clarify the understanding of the topic through the vast information and also show the authentic data which can clear the view of the topic. In the introduction, the issues that arise in the nursing sector also clarify the statement about the objectives of this paper. After that, this paper discussed the overview of the Indian nursing conditions at the different time, while all the data were collected from the article and authentic government sites. Different news related to the health sector and nursing issues included all the information from the newspaper articles. Further, this paper has been discussed based on the 7 themes which show the nursing situation based on the current scenario and discuss the various sides of the Indian health system. The COVID-19 period affected the whole Indian health sector and created challenges for the nurses and as discussed in this paper. These 7 themes are apparent in the view of the nurses' condition before COVID-19 and after COVID-19 through the various data, and those data reflect the death rate of the nurses during COVID-19. Ignorance from the Indian government side has also been mentioned in this paper, and their failure to provide the essential equipment to nurses during tough times has also been discussed in this paper. The importance of the telemedicine during COVID-19 also has been addressed in this paper, and in some remote areas where the government failed to implement the advanced technology, that also alludes to the showing proper view of the current situation in Indian health system. The health sector is the most essential sector from the country's from our countries and which adds to the value to the country's economy as well. Access to this quality healthcare system is a valid for the healthy, productive population, which can participate in the workforce. A sound health system is essential to migrate the disease burden and improve the overall health outcomes. Health is one of the vital resources for all the individuals to improve the physical ability. In this paper, I have covered India is a country that is ranked 1 because of the population. And the government of India in this country is based on the agriculture sector, where most of the population live in rural area. India is divided in 28 states, where the maximum number of states belong to the rural area. The country's government also focus on the rural healthcare sector, intending to provide health services for the vast population. The government funds public hospitals and the private hospitals. And in India, maximum number of private hospitals in urban areas and the public hospitals in the rural areas. In many public hospitals, the number of doctors is deficient and nurses take care of all the patients and also help patients to recover from this disease. My objectives of the papers, as I have mentioned, that this concerns nurses' condition in rural India during and after COVID-19. India, we know that has a vast population and mixed health structure, which helps the paper to provide the proper view of the topic. The main objective of this paper is to clarify the understanding of the nurses' situation in COVID-19, where rural states in India are also through the demanding conditions, and the contribution of nurses before COVID-19 is also remarkable because of their attachment to the patient and to the patient families. India's health system received a shock during COVID-19 that has also been included in this paper to clarify the importance of the topic in front of the readers. Now, the methods which I have used in this is collecting data about the paper. In research studies, two types of data primarily used. One is a primary and another is a secondary data. In research, the qualitative approach is used for the descriptive information, and the quantitative method is used for the aim to provide the numeric data about the current scenario. Moreover, primary data also help to show the death count of the nurses during COVID-19 of India. And in this research, secondary qualitative and quantitative methods are used for the research. All the information that is included in this paper is very essential data completed, which has completed this paper, has got a maximum data collected from the government official website and from the newspapers, which is the most precise information. Then I come to my results. I have an overview of the nursing practices in rural India over years. Only I'm giving the heads of that. I have considered here India's healthcare market from 2008 to 2025 and how much money is spent on this health sector. That is also given in detail.
Suresh ji,
Ji,
can you able to see whatever you have written? Sorry to interrupt you, but whether you can able to see whatever you have written in the slide?
nahi sir, I accept what you said.
So it is better if you wind up with an summary, because it is like it is going out of our mind. We can't able to understand what you are trying to establish actually.
Okay,
Huh?
sir. As per your order, sir.
Huh.
I'm coming to conclusion. I'm coming to conclusion as per the my teacher's order. Here you will find nurses and doctors are the main pillars in this Indian health structure, where they provide various services to patient in rural and urban areas. India is known for their population, and also in this country, the health structure is maintained at a multi-layer where the government participation is higher than any other. And this sector operated in India by the government and some private companies. The country, based on the rural and urban areas, where most of the population belongs to rural area, and this paper based on the condition of the nurses in rural areas before and after COVID-19?
Are you done?
Yes, sir.
But actually, it is not a conclusion, or it is not like this. Actually, kindly make sure that next time wherever you grow, make sure you get to know how to prepare a PPT first. Second, what are the objectives need to be? It is like copying and pasting, nothing in the slide. Okay, sorry, but
I will,
you need to improve a lot.
yes, I will do that, sir.
Because when you look into the whatever nurses you are talking about, you are talking about telemedicine, you are talking about lack of funding from the Indian government, and you are talking about population. You know one thing, during COVID, we were standing at the second, China was standing at the first, and probably our government was good enough that they showed. I don't blindly support someone. It is like somewhat they showed as much as true data they can. But we in world, none of them believe Chinese people how much they have shown the data or something. So it is like without any substantial evidence, we can't blame any government. Okay.
Yes, sir.
But okay, fine. We if anyone is having any doubt, they can ask Sureji, or else we can go with the next presentation. Thank you.
Thank you, sir.
Please unmute yourself and ask the question.
Yeah, I think, yeah, Mr. Suresh. Yeah, I would
Yes,
like to point something that, yeah, I think I would like to emphasize that you need to improve a little bit about the technicalities of the presentation,
yes,
as well
sir.
as, yeah. And also, I think this is a very good topic, that nursing healthcare in rural India during and after COVID-19. And so you have tried to put together all these so many different datas. But I think you should simplify your slides, to talk your point and make relevant conclusion.
Yes, sir. I will improve.
The title is very good, but you have to work a lot on your presentation. Okay. Yeah, thank you.
Yes, sir. I will work on that.
Thank you.
Thank you, sir.
Thank you, Mr. Suresh, for sharing your presentation. Next presentation is of Ms. Shobhana. Please start with the presentation.
Ma'am, I couldn't able to share my screen. The option is like,
Yes, now it will be available.
okay.
Please try again.
Hope the PPT is visible now. Is it visible, ma'am? Hello.
Yes, it's visible.
Good morning, everyone present here. Myself, Dr. Shobhana, working as assistant professor from the Department of Biotechnology, Weltech University, Chennai. And today's discussion is on my research area, that is synthesis and characterization of biological nanoparticles and their study against hepatocellular carcinoma for in vitro and in vivo analysis. Moving on to my presentation. As we all know that nanoparticles are of size range of 1 to 100 nanometer, and they have some unique characteristics of small size with high surface area and volume ratio. So because of the importance of their small size, biodegradable and biocompatibility, these nanoparticles have gained advantages in most of our biological applications. There are various modes of synthesis, physical, chemical, and biological. And in biological, I have chosen to synthesize our nanoparticles using green synthesis method. As it is, why I have gone for green synthesis method is it is biocompatible and it is cost effective. It has non-toxic chemicals and because of their therapeutic ability. Next, as a green synthesis of nanoparticles, some of the advantages are it is cost effective, it is eco-friendly, and also it can be easily scaled up for large scale of synthesis. Other requirements like temperature, pressure, and also toxic chemicals are not present using this green synthesis method. That is why I have chosen this method where the plant extracts will be acting as a reducing and capping agent for the nanoparticle synthesis. So this helps to overcome the disadvantages with the conventional synthesis method. So first, I have synthesized silver and zinc oxide nanoparticles from the seed extracts of Artocarpus histotus, and then I have gassed the nanoparticle. Next, I have did in vitro studies on HepG2 cell lines, further which in vivo anti-cancer study in Balbisi mice was conducted. Moving on to the synthesis part, we have collected the fruit that is Artocarpus histotus and the seeds were depulped. And the seeds were depulped. This is the plant which we have taken, and the seeds were removed from the plant. It is a plant which is commonly found in the southern region of the Western Ghats, and this is a seasonal fruit which is available only during the month of April and May. It has many pharmacological studies were conducted on this different parts of this plant that proves their efficiency for their diuretic, antimicrobial, and also anti-ulcers, anti-cancer activities. So first we have taken the fruit and the seeds were collected, from which the cotyledon is removed, which is then sun-dried for a period of about 7 days. Then these dried seeds were used for the synthesis of our nanoparticles. The seed extract is first obtained by boiling around 10 grams of 600 ml of distilled water, further which they are titrated against the precursors, that is zinc acetate and silver nitrate I have taken here. By drop-wise titration using co-precipitation method of synthesis. After this, the solution is kept overnight for the complete reduction of nanoparticles. Then, which is then centrifuged the next day at around 8,000 RPM for 20 minutes. After this, the pellets are dried to obtain powder, and this powder is being used for the characterization studies. So the figure E, which I have shown here, is where the zinc oxide nanoparticle powder is obtained, and the next one is silver nanoparticle powder. So these are the XRD reports which confirms the presence of nanoparticles, and the particle size is calculated using our Schirr's formula, that is 25 nanometer for the silver nanoparticles, and it is around 20 nanometer, 22 nanometer for zinc oxide nanoparticles. So both these nanoparticles are less than 30 nanometer, which makes it appropriate for our biological application. UV visible spectroscopy of the silver and zinc oxide nanoparticles, where it confirms the presence of absorption band at 420. And for zinc oxide nanoparticle also, it confirms the presence of UV visible absorption band with a band range of 226 and 365 nanometer. Next is the SEM reports which were obtained for our silver nanoparticles, where it is proven to be oval and spherical shaped for the silver nanoparticles, and for zinc oxide nanoparticles also spherical and oval shaped nanoparticles are obtained with the particle sizes of around 15 to 40 nanometer in size. This is the TEM electron spectroscopy that coincides with the SEM results as obtained to calculate the particle size, which ranges from 6 to 26 nanometer for silver, and for zinc oxide nanoparticles, it is around 10 to 30 nanometer in size. So both the SEM and TEM results, it confirms presence of nanoparticles with a size range of less than 30 nanometer. This is obtained to obtain the potential, zeta potential of our nanoparticles, where for silver nanoparticles, it have negative charge, and for the zinc oxide nanoparticles, a positive potential value of 4.68 millivolt is seen, which makes the synthesized nanoparticles stable. The FTI spectroscopy of the seed extracts and the nanoparticles also confirms the presence of the phytochemicals, which acts as the capping and the reducing agent for the formation of the both silver and zinc oxide nanoparticles. And different functional groups were obtained based on their vibrations and the stretch bands, OH, NH, and CH stretch bands, which were present. Moving on to the application part, where the anti-cancer activity in vitro studies is first done using this different assays like MTT, and different staining techniques were used to analyze the results. And the cell cycle analysis was carried out using flow cytometry to measure the cell cycle distribution and also the percentage of apoptotic cells. First, this MTT assay results, which indicates that silver and zinc oxide nanoparticles proved to be cytotoxic against the HepG2 cell lines with a inhibitory concentration, minimum inhibitory concentration of 40 micrograms per milliliter for silver And for zinc oxide nanoparticles, it was observed to be 15 micrograms per milliliter. The different staining techniques that were obtained were done here. And the first one is DAPI staining. We're using this staining. The fluorescence images shows the apoptosis had occurred because of the nanoparticles in our HBT cell lines when compared with the normal cells that did not show any apoptotic cells. Next is a dual staining technique. Using this technique, and it is also after viewing under fluorescent microscopes. In control, we couldn't find any apoptotic cells, whereas the HG2 cells were treated with different concentrations of silver and zinc oxide nanoparticles that indicated apoptotic activity. This colored blue, orange colored cells which indicate the nucleus shrinkage damage that were exhibiting necrosis in the HG2 cell lines when treated with both this silver and also zinc oxide nanoparticles. This staining technique is done to measure to see the release of ROS, that is, this cytotoxic activity is due to the release of ROS in the treated cells, and this also confirms the cytotoxic ability of our nanoparticles synthesized using the green extract, means green synthesis method from the plant sample Artocarpus seed. Our flow cytometry results showed that a significant cell cycle arrest was observed in the G1 phase, and also a decrease in the cell count was observed in S and G2 phases for both the concentration of this IC50 concentration of the both the nanoparticles. So this study indicates that the nanoparticles induced both apoptosis and also arrest at the G2 phase itself. Hence, our anti-cancer study results confirms that these zinc and silver nanoparticles can be used as showed efficient cytotoxic activity against the HG2 cell lines, liver cancer cell lines. And based on our study, the study was further extended to in vivo activity. Moving on to our in vivo activity, as you all know, this hepatocellular carcinoma is the most common type of liver cancer which occurs in adult. And also it is the cause of death in people with cirrhosis. And doxorubicin and silymarin are the commercially available drugs which are used for the treatment. So this study was conducted in male Balbisi mice, where the mice and the treatment and how it was given is indicated in the next slide. So this is where the mice were taken and were divided into 6 groups. And for the initial period of around 3 weeks, CCL4 were administered to induce liver cancer in the mice. And at the last 2 weeks, within this 3 weeks, the last 2 weeks, phenobarbital was added to the diet of the mice to induce liver cancer. That during this period of around 5 weeks, 6 mice were sacrificed and were observed for the tumor development. After which the therapeutic was started for a period of around 2 weeks, where each day the mice were given about 30 milligram per kg of injection through intraperitoneal mode. And CCL4 was also administered through intraperitoneal mode, and all the mice were sacrificed after a period of 2 weeks. 2 weeks by administering chloroform. Let's see that what was the effect of the nanoparticles which were administered. These are some of the photographs which were taken during our study. So on comparing this body weight analysis, the body weight of the negative control was noted to have a decrease, whereas in all the other groups had a steady increase in the body weight. This confirms the formation of tumors in the negative control group, where no means therapeutic agents was given for this negative control. This is the sections of the image which are taken during the 3rd week of the induction time, where during the induction time to CCL4, where central vein congestion and portal inflammations were seen in hepatic tissues. And at the 4th week, also it forms a focal congestion. And after the phenobarbital diet, we were able to see during the 5th, 10th and last 10th days, we were able to see the tumor promotion with the phenobarbital diet. During the 5th day, it was initially with focal hepatocyte necrosis. whereas necrosis with degenerative changes were observed at the 10th day with the phenobarbital rich diet. Next, moving on to our biochemical analysis. This is the biochemical analysis for the liver enzymes which were analyzed, where negative control mice showed high levels of ALP, which includes necrosis in hepatic tissues, whereas for the other experimental groups, this liver enzyme levels indicates the therapeutic efficiency, which are observed for both the seed extracts and also for the silver and zinc oxide nanoparticles. And these values were represented with the mean and standard deviation plots. Thank you. Any queries? Hello?
Yeah, I think overall
Hello,
it was
sir.
good. Yeah, can you hear me?
Yes, actually in the middle, I think this
Hello.
the slide
Yeah,
got.
you're Sovana, isn't it?
Yes, sir.
Sovana. Yeah, so yeah. Yeah, I think your presentation was good. Content was fine.
Yes, sir.
And yeah, I would like to emphasize here one point that I think this is about green synthesis.
Yes,
I think
sir.
this is the same. This is a 100 years old story. The same story which has been used by many people around the like all over India
Okay.
for graduating with their PhD thesis. And I think so. I would like to ask you what is new thing you have done here,
Sir,
and also why you did not use the control groups in your all of those analytical experimental data in like for example in the FTIR and all those you have only shown only the experimental group data, and also there are too many data issues in even in the flow cytometry data, and some of the labels are also missing in this in your immunofluorescence microscope data. Can you go to your immunofluorescence microscope
yes,
data?
sir.
Yeah. What is this silver? There is no scale bar in this.
Okay. Yes, sir.
So
Scale
what you
bar
are
is-
trying to make point? What you are trying to make
When
point
comparing to
here?
the control and the cells which were treated with the nanoparticles, it showed like apoptotic cells were observed for both these
So
treated.
this is
Yes.
what kind of staining it is? Is it annexin 5 or what? What is the staining
This
about?
is DCFTA staining. I have indicated on the top of the slide.
Okay, and so this is before and after
This
treatment
is
of silver nanoparticle.
yes, before and after treatment of the nanoparticle.
So why you have used this silver
The staining.
nanoparticle for your for the liver cancer in vitro and in vivo model, isn't it? That's
Sir,
what you have
my
shown, the
further yes,
FG2.
I am planning to extend my study, the encapsulation of the drug into the silver nanoparticles. This is like the preliminary study. I have
Yeah.
currently I'm working on it and I have kept it as a base. And now I'm planning to encapsulate the drug into the silver nanoparticles and go it for the preclinical.
I understood, but what's the point? I mean, why you want to use the silver nanoparticle? Because most of the nanoparticles will also have the toxicity,
Yes,
toxicity,
toxicity of the
even they,
nanoparticles were also studied for the same study. And the
yeah,
toxicity, it was observed to be very, very mild. Only in the case of liver and kidney, there was very mild toxicity was observed. And
okay.
for zinc oxide nanoparticles, even that toxicity was not observed.
So are you doing PhD or what with this
No,
with
I
this
have
work?
completed. It was completed 4 years back. It
Or
is
you are
preliminary data. I'm extending my study. I'm just encapsulating drug into it. Currently, I'm working on it.
or you are a faculty, isn't it there?
Yes, yes, yes.
Okay, yeah, it's fine. I think this kind of study, I think anyway, I just don't want to make any comment here, but I think it's not useful, to do this kind of. We should do something new,
No,
and there is no point of you doing this. I don't see any meaning in this work itself. Yeah. Yeah, if you search even in the PubMed, I don't want to be harsh here. Yeah, but if you see even in the PubMed, if you just search the silver nanoparticle, every year 2000 papers is being published all over the world, and I think you can see even in the clinical study. Yeah, I think because the basic thing here, what people do is they use those they use some of the bio or like biological material as one of the catalysts, because that acts as a reducing agent. That is the basic point what people like to make here, you know. But it is not convincing here, and even there are so many data issues. And I would like to just emphasize that you should do something better research, you know.
Oh,
Anyway, thanks. Yeah,
I
thank you.
will find my work now. This is a very good work. Okay, thanks, sir. Thank you. Thank you.
Thank you.
Okay, we can go with the next presentation.
Thank you for sharing your extensive expertise. For the next presentation, Bhavna Varmani, please start sharing your screen.
சொல்லுங்க.
Ms. Bhavna Varmani, please share your screen.
Hello everyone, is this visible?
No, the screen is not visible.
It is showing request to allow multiple presenters sharing.
Ms. Bhavna Varmani, the screen is not visible. Please try it again.
Is it visible now?
Yes, it's visible now. Thank you.
So, hello everyone. Greetings for the day to the evaluators, organizing team, and fellow participants. I'm Bhavna Varmani from Biomedical University of Science and Technology. I'm glad here to be the part of ICBHS 2024. Topic of my presentation is synthesis and therapeutic evaluation of silver encapsulated fluoroglucinol for neurodegenerative diseases. These are the contents for the presentation. Neurological disorders are posing a great challenge for mankind and are the leading cause of disability and deaths globally. With a rising age population and poor lifestyle and limited resources to the better healthcare, the magnitude of the burden is more on developing countries. Neurological disorders involve cerebral stroke, Alzheimer's, Parkinson's, brain tumors, epilepsy, and the common symptoms of such disorders are dementia, locomotor dysfunction, facial paralysis, epileptic seizures, loss of neural functioning, and connectivity. The major factor that affects in these diseases is the blood-brain barrier, which is a neuroprotective barrier in between the blood supply and the brain tissues. Brain tissue, blood-brain barrier allows nutrients flow to the brain tissues and avoid toxins and macromolecules to pass through it. But it has been observed that therapeutic drugs are also of a particular size which are not able to penetrate from the blood-brain barrier. But in the disorders, the blood-brain barrier gets disrupted, and we aim to use that distributed blood-brain barrier to cross the drugs in the form of nanoformulations. Therefore, we are targeting to encapsulate our drug in the nano formulation and so that it can infect the infected region in the best way. So nanotechnology and neuroprotection. Nanotechnology is a wide approach that has been used in offering targeted drug to the infected sites. It has high specificity. It's biocompatible in nature, biodegradable, have a potential to penetrate blood-brain barriers. It has high loading capacity. There's small dosages required due to high retention. So nanomaterials could be organic or inorganic in nature. Organic nanomaterials are basically having carbon compounds like liposomes, lipids, polymeric nanoparticles, etc. Whereas in organic nanomaterials include metallic nanoparticles, magnetic nanoparticles, carbon dots, or carbon nanotubes, which is considered an inorganic nanomaterial. Further, for this study, we have chosen silver nanoparticles and fluoroglucinol. Silver nanoparticles have established antibacterial and anti-inflammatory impact. It is biocompatible in nature. With literature, we have found that it has a potential to penetrate blood-brain barrier via transcytosis, and it has multiple applications in terms of wound healing, cancer treatment, etc. Fluoroglucinol is obtained from brown marine algae. We have a molecular weight of 126.11 gram per mole. It is formula of 13. It has molecular formula 135 trihydroxybenzene, 3 OH groups. It has established antioxidant activities, inflammatory characteristics, and it activates its impact via NF-kappa beta signaling pathway. We have chosen fluoroglucinol as there are very few number of papers have been mentioned which includes fluoroglucinol nanoparticles for targeting the site. So we aim to encapsulate fluoroglucinol in the with silver nanoparticles. So aims and objectives, these are my basically, I'm representing my whole work as objective 1, 2, 3. In this presentation, I will represent as per objective 1, that is synthesis and characterization of nanoformulations. This is a pictorial representation of my work where I have synthesized the nanoformulations and then done the characterization using PSA, UV, FTIR, SEM, XRD, etc. Further, these are the results. The results we have achieved. The first table represents the hydrodynamic diameter and PDI and drug loading efficiency of the black nanoparticles as well as the 3 nanoformulations. We have used 3 different concentrations of the drug, that is fluoroglucinol, that is 5 mg per ml, 2.5 mg per ml, and 1.0 mg per ml. The hydrodynamic diameter of the black KG nanoparticles was 29.60, while the nanoparticles A, that is formulation A, has the hydrodynamic diameter of 60.59. It has been observed that higher the concentration of the is a drug, smaller is the size of the nanoparticles. The PDI represents 0.5 to 0.4 in between. There is a small polydispersed nature of the nanoparticles have been observed, and the drug loading efficiency was excellent, which was achieved as 93.6, 92.2%, and 91.8% for the respective nanoformulations. Say the graph here represents the graph here represents the drug release patterns, which shows a cumulative, a constant drug release pattern for on the concentration basis in usually 8 to 10 hours. Next represents the FTIR spectrum for the and the bond stretching for the formulations, the blank nanoparticles, and then fluoroglucinol drug with reference to the nanoparticles. After that, this is the UV spectra and the XRD spectrum. The XRD spectrum represents the crystalline nature of the nanoparticles with FCC centered structure, whereas UV represents that the formulation of nanoparticles as pure drug. The purple graph represents a pure drug which has absorbance at 265, and the blank AG nanoparticles, silver nanoparticles, has absorbance around 425 nanometers. After that, three formulations represents the peaks at 265, near about 265 and 425, which represents the encapsulation of the drug and the silver nanoparticles. After that, I'm representing the SEM image of the drug-loaded AG nanoparticles, which represents the spherical morphology of the nanoformulations with dispersed size of 36.4 nanometer, 37.9 nanometer, 87.4, 81.4, and 32.4, with an average of 55.6 nanometers. Further, we have evaluated the hemocompatibility and antimicrobial activity of the nanoformulations. Hemocompatibility basically represents the impact of the nanoformulations on the red blood cells. So our polite donor donated blood for this experiment, and the RBCs have been seen. We have checked the impact of our nanoformulations with respect to Triton X, which ruptured the RBCs, as shown here with the red vials that shows the ruptured RBCs, and the hemolysis of any compound or material that impacts the RBCs more than 5%. 5 to 6% are considered as hemolytic in nature, while our nanoformulations have shown around 1% hemolysis, that is considerable. It kept the RBCs intact. Further is the antimicrobial activity of the nanoformulations with respect to gram-positive and gram-negative bacteria. Bacterias. The first table represents the inhibition zones, and second represents activity index and inhibition percentage, which is with respect to the standard drugs. And it has shown that it has an inhibition percentage of more than 50% for Bacillus subtilis and E. coli. So conclusion of my work is that we have designed three formulations with different concentrations. FTIR and UV has established the formation of AG conjugated PG nanoparticles. The drug release patterns are concentration dependent, and we have observed that higher the concentration, lower is the hydrodynamic diameter. That is around 60.59 nanometers. The XRD graph tells about the crystalline nature of the nanoparticles with STC structure. SEM images represents the spherical nature with the polydisperse polydisperse nature of nanoparticles with average size of 55.6 nanometers. It shows excellent homocompatibility and significant antimicrobial properties have been observed, which is more than 50%. Thank you. I would like to special thanks to my supervisor, Dr. Rajesh Thakur, and master students Rashna and Tamanna for their support throughout the study. Thank you.
Hi, Bhavna. I think, yeah, nice presentation and the content. And also your topic is relevant with this because you have chosen the silver nanoparticle again. But I would like to ask why did you use antibacterial test? But here you have in the title you have mentioned you are using it for neurodegenerative diseases. Can you
Yes.
justify this?
Yes, it is due to the time constraints. I am also working on the antioxidant activity and many more. Antibacterial activity is the basic activity that we proceed from that is a preliminary study that we focus. Antioxidant and other activities are not mentioned here.
Again, that is not a good answer. You should say sorry, I did mistake, and I should be more I should be more cautious about the title and what you presented in your conclusion and the content. That should be the exact answer. Because you made a mistake. You made certain title, but you put something in your conclusion and the content. That should be the exact answer here.
Surely,
Yeah, and
I understand.
yeah, and next is why. Yeah, it's fine. So next is in the neurodegenerative. If at all you are doing neurodegenerative disease, if I am trying to just ignore what you presented in your content, what sort of neurodegenerative diseases are you trying to focus?
For my studies, I am particularly focusing on cerebral ischemia.
Cerebral ischemia. So what kind of model you will be using in the in vitro and in vivo?
I have done this work previously as well, and where we have used Macau model. But right now for my studies,
What model? What model? Sorry. Can you go slow? What?
Sure. Bilateral carotid artery occlusion model, Macau model. And now for my studies, I will follow a Macau model, that is middle carotid artery occlusion.
So what did you do in that model? You irrigated some artery, and what did you?
Yes, I have done that part. For this, first we anesthetize the animal, and then we dissect. Dissect the make an incision at the neck, and then separate the carotid artery, and use it after insert nylon.
Then how it is impacting the neurons? Like which kind of neuron you are focusing? Cortical, hippocampus?
So it is basically a kind of focal model that impacts the one part of your brain, which impacts all the hippocampal as well as cortex region.
Okay. Thank you.
Thank you so much.
Thank you for sharing your presentation. Next presenter is Upasana Devi. Please share your presentation.
Good morning to all. Am I audible?
Yes, good morning.
Is my screen visible to all of you?
Yes, it is visible.
Good morning to all. Good morning to organizers and all the judges. This is Upasana Devi, Assistant Professor from Department of Chemistry, RGPG College, Meerut.
Miss
Today,
Upasana,
my topic. Yes, ma'am.
Sir, your screen is not visible. The PPT is not visible, the screen is visible.
Okay, but I have shared, ma'am.
Just click on the PPT.
Click on the PPT. Or not?
Your folder is visible.
Just a minute. I am sharing again.
Yes.
Sorry for being late.
Yes, it is visible now.
Is it visible, ma'am?
Yes, it is. Thank
Yes, sorry for being late. My topic for today's presentation is synthesis of some thiazole substituted flavons and their computational studies. Am I audible now?
Yes, you are audible.
Yes, as far as the introduction is concerned, flavons belongs to the flavonoid compound. They are secondary metabolite and they cannot be synthesized by the human and animal body. So they can be taken in a diet. The flavon and all the flavonoids basically contain a chromone moiety. This chromone moiety, as far as the literature is concerned, Khelin was the first drug which contains the chromone moiety, and it was used in 1950s as a in the disease angina pectoris and respiratory syndrome. This Khelin drug was extracted by the Annie Wisnega. So here I would like to tell you that the chromone is the main moiety which is present in all the flavons and flavonoid compounds. Chromone moiety is basically formed by the two rings. One is the benzene ring and one is the pyrene ring. Both the rings are fused together to each other. And the one carbonyl group is present at the fourth position of the chromone ring. So on the basis of the substitution on the chromone ring at the second, third, and fourth carbon of pyrene ring, flavons are classified into three categories. These three categories are flavonoid, isoflavonoid, and neoflavonoid. Thiazole. Thiazole is the important moiety in heterocyclic compounds with diverse biological activities. And in literature, we all know penicillin has a thiazole ring, and it was used first as the effective antibiotic, and it also used as an antimicrobial drug. This is the structure of thiazole. So aim of my present work is based on well-documented application and literature of review and all the studies from structural activity relationship, it was found that there is a gap between the fused compound and their activities in the pharmaceutical field. So here we have decided to synthesize fused compounds of thiazole and flavone. So from the structure activity relationship, it was decided to synthesize heteroaryl chromones and flavones. Here the heteroaryl ring which I have taken is thiazole ring, and the chromone and from the chromones and flavones in this series I have taken flavones. So here the thiazole ring is substituted at the position of flavone. So we have synthesized 7 new compounds with this substitution. As far as the experimental is concerned, all the materials and methods are used, mentioned here. These are the compounds, thiourea and phenylthiourea. All the substitute thioureas are used here, and the chloroacetyl chloride for the Friedel-Crafts acetylation, DMF, DMSO, all are the solvent which are used. Melting point recorded in the capillaries, open capillaries, and concentrated sulfuric acid bath and recorded as it is. FTIR recorded in Carey 630 FTIR ATR, lambda max expressed in centimeter inverse. NMR spectra was observed in 500 megahertz NMR at Geol's spectrophotometer, and mass spectra was also observed on the same. TLC was used to monitor the rate of reaction. So here, first of all, we have synthesized the precursor compound, that is 6-chloroacetyl flavone. So for this, we have applied 3-step reaction. In first step, 2-hydroxyacetophenone and benzaldehyde were reflexed in ethanol. It is based on Claisen condensation. So chalcone was formed by the 24 stirrer on magnetic stirrer. After that, a solid was obtained, that is filtered, cooled, and washed with water and used for the further step. In next step, this chalcone refluxed with iodine particles in solvent DMSO for 5 to 6 hours on oil bath, and after 5 to 6 hours, a solid was separated, that is filtered, cooled, filtered, dried, and recrystallized with ethanol. This compound is prepared as a flavone. So for the last step, flavone undergo for the Friedel-Crafts acetylation by the chloroacetyl group, by the chloroacetyl in presence of aluminum trichloride, and dichloromethane was the solvent. So in this step, flavone is substituted at the 6th position by chloroacetyl side chain. So here it is the precursor compound of our further synthesis. This is the physicochemical data of precursor compound. And as far as the result of NMR and IR is concerned, one new carbonyl group has been introduced in the former chloroacetyl side chain. So for this, the value of carbonyl stretching is 1642 centimeter is arised. As far as in NMR spectral studies, one singlet for 2H methylene group of chloroacetyl side chain arise at 1.25 delta with different peaks of aromatic region in starting compound. This is the scheme of rest of 6 compounds which were synthesized by the Hans process, in which precursor compound condensed with substituted thioureas, and this mixture is taken in equimolar amount and refluxed in ethanol for 2 hours. After completing the reaction, a solid was separated, cooled, and filtered and washed with water, and these 3 compounds were the derivatives of flavones with the fused thiazole ring at the 6th position of benzene ring of flavone. So here all the compounds recrystallize with DMF, dimethyl formamide. In next step, 3 more derivatives were synthesized by the acetylation at the nitrogen of thiazole ring, which is present at the 2nd position of thiazole ring of thiazole flavone fused compounds. So here is the physicochemical data of all the synthesized compound in step 1. And this is the data of synthesized compound in step 2. All over 6 synthesized compounds were synthesized. This is the result and discussion in first step, where the precursor compound converted into a thiazole flavone hybrid, in which the thiazole ring introduced as the 6th position of flavone ring. So with the introduction of thiazole ring, one additional peak of NH stretching for 1 degree amine and 2 degree amine between 3,350 to 33,000 centimeters inverse appeared, along with the peaks of CO stretching that is already present in pyrene ring in the starting compound between 1706 to 1640 centimeter inverse. This is the resultant discussion of IR and MR of the last 3 derivatives, in which the acetylated derivatives are formed in the last step, in which one extra CO stretching frequency CO stretching peak arised for the NCOCH3, that is the substitution of nitrogen of thiazole ring at the second position. So all the 7 synthesized compounds were studied for their computational studies, and for this we have used PKCSMS software for ADME properties, in which adsorption, distribution, metabolism, and excretion were observed. Physicochemical properties have been evaluated further by the using Swiss ADME software. For the computational studies, we docked all the 7 compounds, and for this there are 2 steps. First is ligand preparation and second is target selection. And we have selected the target, that is one anti-COVID-19 target, PDV file number 6Y2E. Factors basically which were used for the molecular docking are hydrogen binding interactions.
Sorry to interrupt you, Sana ma'am. Please wind up quickly. Your time has been exceeded.
Okay. These are the screen compounds. These are the physicochemical properties of screen compounds with various properties. This is the pharmacokinetics properties of screen compounds. And this is the molecular docking result of screen compounds with anti-COVID-19 protein. With respect to the standards, hydrochloroquine and umifenosvir. At the last, in conclusion, I would like to conclude this, that out of the 7 compounds, compound 8A3, that is the thiazole flavone hybrid, is showing the good results with all the factors, that is delta G, full fitness score, energy, and hydrogen binding interactions. So from the computational studies, it is extracted that we can go for the computational studies or docking studies before going the wet lab, because wet lab is the time cumbersome and the time cumbersome process, and it also takes time and money. So we can escape from wasting our time before going to wet lab if we do docking studies for the synthesized compound. Thank you.
Thank you for your presentation. We can now begin the Q&A session.
Yeah, I think nice presentation. So I would like to ask what sort of pharmacological effect you would like to examine after that for these compounds. And have you
Sir,
already
yes, sir.
Yeah. And have you already synthesized this in lab, or is it
Yes,
only?
sir. My main work is synthesis, characterization, and antimicrobial analysis of the compounds. But for the additional work, I did this docking studies, sir.
Okay, so what sort of pharmacological effect you are expecting then?
Sir, as far as the pharmacological aspects, sir, all the compounds showing moderate activities, as renal, substrate, MES activities or hepatotoxicity. But out of 7, 1 is showing best in all the aspects. So we can say that we go for further synthesis by taking the initial compound of that compound.
Okay. Yeah, I think, and yeah, it's fine. I think there are many typos in the slides. Okay. Thank you.
Thank you, sir.
Thank you, ma'am. We shall go with the next presentation.
I hope all the doubts and questions were clear. Let's proceed with the next presentation. Our next presenter is Ms. Shweta Sabharwal. Please start with the presentation.
Good morning, everybody. Am I audible to everyone?
Yeah, it's your audible and your screen is visible.
Just a second. Good morning, everyone. My name is Ms. Shweta Meyer Sabharwal, Assistant Professor at the School of Computer Science and Engineering, Galgotia University, Greater Noida. And today I'm going to present on the topic of machine learning applications in predicting disease outbreaks. So the outline of my presentation starts with the introduction and research motivations, followed up with the research objective, related work, research contributions, methodologies, conclusions, future scopes, and references. Well, the introduction, first of all, the most important part starts with the global impact of diseases outbreaks and the need for the accurate predictions. So when we look into the disease outbreaks profoundly, which impact the global health, economy, and the social stability. And the outbreaks like the COVID-19 pandemic, Ebola, and the Zika have caused widespread mobility and the disrupted global trade and the overwhelmed healthcare systems. So the timely predictions allow the governments and the healthcare organizations to implement the target interventions such as the quarantines, travel restrictions, vaccinations campaigns, and the resource allocations. So the accurate predictions also enables the better preparedness and helping to mitigate the economy and the social impact of the outbreaks. The second important part is how the machine learning as a powerful tool for the outbreak predictions. So in the recent years, we have observed that the machine learning has emerged as a revolutionary tool in the field of outbreak predictions. So unlike the traditional statistical methods, which rely heavily on the predefined models and the assumptions, the machine learning can process the vast and the complex data sets, which helps in identifying the patterns and make the predictions without the need of the explicit programming. ML algorithms can also analyze the diverse data types, which is towards the environmental factors, demographic informations, and even unstructured data from the social media, which helps in detecting early warning signs for the potential outbreaks. The second important part where we are talking about is the integration of the machine learning with the epidemiological data for the enhanced diseases surveillance. So the epidemiological data, which includes the information on the disease incidences, the prevalences, and the transmission patterns, which provides a rich source of information for the ML models. And by combining this particular data with the other sources, such as environmental conditions, population density, and the mobility patterns, the ML algorithms can offer more accurate and comprehensive predictions. Not only this, we can improve the accuracy and the timelines of the predictions. The integration of ML with the epidemiological data helps in public health authorities respond more effectively to emerging threats, optimize the resource allocations, and ultimately protect the public health on a global scale. My research objective is basically been into the two folds. The first fold is where we were able to review the advancement in the machine learning applications for predicting the disease outbreaks. And the second fold is to evaluate the effectiveness of various machine learning algorithms in real-world scenarios. The related work which has been done in the machine learning techniques are categorized into four parts. One is the supervised learning. The second one is unsupervised learning. The third is the deep learning. And then we have a hybrid models. So the supervised learning is basically including some decision trees, random forest, and SVM algorithms, which helps in train.
Sorry, but
Sure.
it is quite basic and detailed. You can go ahead with your actual
Okay.
methodology. That will be
Correct.
best.
Yeah. So the methodology which we are talking about is the workflow of the machine learning for the outbreak predictions. So here we have talked about how the data has been collected, the data preprocessing towards the feature engineering and the modeling or training, then evaluation and the predictions. So these are the basic workflow of our particular methodology, and in that we have done the comparative analysis for those particular machine learning models. So the comparative models has been used as a decision tree, random forest, SVM, CNN, RNN, and also the hybrid, which is included with the RF plus CNN, which gives you the evaluation and the performance of ML models in predicting the disease outbreaks in several matrices. And those matrices which we have used, including the accuracies, precisions, recalls, F1 score, and AUC curves. So if we can see that the hybrid RF and CN model has been giving you the highest accuracy, that is of 94%, with compared to the decision trees, the basic algorithms of MLs, that is towards the decision tree, that is of 85, random forest with 90s, SVM with 88, CNN 92, and followed with RNN as 91% of accuracy. So the comparative analysis of machine learning models have also used with the case studies and applications. So if we look into the ML models predicting the spread of COVID-19, dengue fever, and the influenza has demonstrated significant success in various regions of globally. So in COVID-19, we have the SS of ML models, which is effective in predicting the infection rates, mortality, and the healthcare resource needs. So the approaches that has been approved is the time series forecasting, sentiment analysis on the social media data, and the epidemiological models. And the impact has been towards the improved response strategies and the resources allocations, early warning systems. The second one we have taken as an outbreak disease is the dengue fever, where we have evaluated the ML ability to predict the outbreaks based on the climate data, historical incidents, and the vector data. And the approaches which we have opted for the regression models, spatial analysis, and the feature engineering from environmental data. The impact which we have seen is the enhanced surveillance and the targeted interventions improved public health responses. The third outbreak disease which we have talked about is the influenza, where the analysis of machine learning role is predicting the seasonal flu trends and the outbreaks. The approaches that we have talked about is predicting the modeling using the historical flu data, Google Trends analysis, and the genetic algorithms. So better vaccine developments and the distribution strategies improve seasonal preparedness also. The conclusion which we have come up with is the ML technique offers a significant potentials for improving the disease outbreak predictions. Secondly, the accurate and the timely predictions can lead to the proactive public health responses as well. The third one is the ongoing research is needed to address the challenges and enhance the efficiency of the ML models. We have could be addressed because the future research could address the challenges such as the data quality and the availability. Moreover, the model interoperability and the integrating domain knowledge from the epidemiologist to further enhance the ML model in the outbreak predictions. These are the certain references which has been used throughout my research analysis. Thank you for your attention, and I'm open for any questions you may have.
Ma'am, actually, I wish to know deep about your data set because I'm not getting your presentation probably. Might be I missed somewhere.
Well, ma'am, right, sir. Well, sir, I have actually had a analysis of how my machine learning application is been helping me in predicting the disease outbreaks. And the disease outbreaks that I have taken is related to three, that is
Fine,
COVID-19.
ma'am. Fine. What about the data set? From where you have taken the data set?
The data set has been taken from the GitHub, ma'am.
GitHub.
Yes, sir. The data set which I have received from the GitHub, and according to those particular data sets, I have tried all the ML algorithms, and I could find out that if I use a hybrid one, that would be giving me a more better accuracy rather than using the traditional ML algorithms.
It seems it is very basic, ma'am, to me.
Okay.
Because they were like actually you are told about the supervised and unsupervised. Okay, fine. The
Yes.
thing is that in supervised, if we are looking into currently they are like deep learning. It is being extensively used. There are several methods in that also, right? It requires
Right,
lot
sir.
of data, and it is like the deep learning is based on CNN.
Correct. CNN and RNN, sir. Right, sir.
CNN with actually neural network, you will have a single hidden layer. Here we will be having multiple hidden layer.
Right, sir. Right, sir. Right, sir.
So actually, it is like you need to work hard, and might be you need to if it is possible shift towards any particular application because it is like the data which has been provided over there, they might be focused on single aspect. Getting my point?
Correct.
In a region.
Right, sir.
But as we are like our demography, it is like very vast and it is like distributed, and several data has not been shown on public. So it is better, and the one which you are using, it is like very basic models.
Correct, sir.
So what I suggest is that you need to go focus on try to get some other data set which has social impact. For example, we are working on fetus biometric parameter estimation. We have developed our own architecture, attenuated network with a double unit.
Correct, sir. So definitely, I'll work upon it, sir.
So you can go on.
Surely, sir.
Hello.
Hello.
Yeah, Miss Sudha,
just
I
go
think.
on
Can
with
you?
the particular. Yes.
Yeah, go ahead, sir. Yeah, sir. Yeah, you can talk. Yeah.
That's it, ma'am. It will be good if you go on work with some real-time application scenario, because
Surely.
whatever I noticed, it is a very basic
Surely, sir. I'll look. I'll
and
definitely
it
go
was
for
not
it.
much deeper into it.
Correct, sir.
Okay. All the best. All the
Thank you.
best.
Thank you so much, sir.
Hello, ma'am. Can you please
Hello.
go to, yeah, nice presentation. Can you please go to the slide where you showed about the accuracy, the accuracies of different kind of model can you go to that one?
Sure, sir. Sure, sir. Yes, sir.
The table, yeah. So here, if I can see here, so here all these AUC, all these parameters, what you have shown. So I would like to, I would appreciate if you could show what are the attributes you have selected based on what data set. Is there any
Okay.
slide, or did I miss something, or
No, sir. I have not included
no?
that particular
Okay.
slide, as well as I have not included the curve also, sir, for this.
Yes.
ROC and
So
AUC curve can be included, sir, I believe.
yes, so I think what you could have done is like, first of all, what is your objective? Because you are trying to predict the disease outbreak, isn't it?
Correct. Yes,
The
sir.
disease outbreak. So for concluding that disease outbreak is happening, what sort of attributes you are talking about? So I would appreciate if you could show me what all attributes have already been shown or depicted in those data set which you have acquired from GitHub, and
Mhm.
also the way you have shown your references in the last slide, rather
Yes,
than
sir.
that, you could have shown those references in every slide where from where you have taken which data, because
Surely.
nowadays everyone is
Correct.
doing machine learning,
Yes,
and
sir.
your work is quite interesting, like a lot of people are taking data set
Mhm.
from UC browser machine learning, or even they are
Yes,
taking
sir.
data set from even Kaggle, and of course I think
Yes, sir.
Professor Avnes, he is quite important person in this field. He can tell
Yes, sir. Yes, sir.
better than me. But because I have also done, I have worked on CNN for last 2 years.
Yes, sir.
But here I think CNN is not applicable in this data set. But at least I have to see what kind of data set you have
Surely,
taken,
sir.
and from where you have taken all those details we need,
Surely,
and
surely, sir.
it seems very haphazard, and
Correct.
also the quality of presentation is good, but quality of content should be more better, yeah.
Surely, sir. I'll look.
Yeah, thank you.
I'll
Thank you.
definitely do it.
Yeah.
Thank you for sharing your presentation. Now our next presenter is Pranjali Saxena and Bhavini. Please start with your presentation.
Hello. Ma'am, my slides are visible?
Yes, it is.
Yes.
Okay. Ladies and gentlemen, a very good afternoon to all. I'm Pranjali Saxena, lecturer at JSS University, Noida. I want to extend my sincere and heartfelt thanks to the organizing committee for giving me a remarkable opportunity to present my work at this platform in front of distinguished judges and audience. My topic for presentation is transforming health, the role of automation and robotics in medical advancement. 1 minute, ma'am. Okay. Yes. The healthcare industry stands at the cusp of revolutionary transformation driven by the convergence of automation and robotics. This dynamic duo is forced to redefine the way we diagnose, treat, and manage illness, ultimately leading to a more efficient, precise, and personalized healthcare experience for patients worldwide. The rise of automation in medical practices. Number one, automated patient check inserts. Second one is streamlined appointment scheduling, enhanced data analysis, improved accuracy in billing. robotic advancements in surgical procedures, minimally invasive surgery, enhanced visualization, improved outcomes, enhancing precision and reducing human errors. These robotic automation, this is minimizing those errors, increased accuracy and consistency, enhanced efficiency, improving patient outcomes and experience, personalized treatment plans, early disease detection, improved patient engagement, enhanced patient satisfaction. Moreover, it helps in streamlining hospital operations and logistics, like automated supply chain management. It is very helpful in this. Efficient patient flow, real-time data tracking. One minute, ma'am, this slide is not moving.
If you're facing trouble, please reshare the
Ethical
screen.
considerations and regulatory framework. Yes, ma'am. Data privacy and security, algorithmic bias, job displays transparency and accountability. Some case studies which I studied, in which these implementation and effects of automation and robotics can be studied. The use of robotic surgery in urology. In this, Da Vinci surgical system is very useful. The next was implementation of automation in pharmacy. In this, key findings. 1 minute, ma'am.
If you're facing some problems, please try to reshare the screen.
No, ma'am, it's okay. Not working. Then implementation of automation in pharmacy, the case of auto dispensing system is helpful and providing very fast all work. Then next example was robotic exoskeleton for rehabilitation, a case study in physical therapy. The case I studied, in this also these robotics were very helpful and they were for physical rehabilitation in patients with spinal cord injuries. Then next was automation in radiology, evaluating the impacts of AI in diagnosing images. Then the concluding part of my presentation was that what will be the future and what is in the future is helping. The future healthcare integrating automation and robotics, it is helping in precision surgery, personalized medicine, artificial intelligence and diagnostics, virtual reality and augmented reality healthcare. Thank you. Thank you for listening, sir.
Thank you for sharing your presentation. We can now begin the Q&A session.
Ma'am, it was like summarizing what you wish to do, right?
Yeah, sir.
So what you actually looking into do, ma'am? We like it was like very speed and it was good actually.
Sir, actually, should I explain in Hindi what I wanted to explain through my PPTs? Are you comfortable with Hindi language?
Ma'am, but we need to look in a public forum whether anybody else
Okay,
they might be
I'll
facing some problem.
no. Actually, sir, the idea behind my this work was I studied many literatures and I searched all papers and many journals from wherever I can get the matter. What happening is that everybody is not aware with the robotic system and what type of help they are getting. Only learned people, they are knowing that automation is very helpful in healthcare sector. Still, there is a drawback that everybody don't go for that treatment as its cost is very high. But through this presentation and if we can spread this message to others also, more steps will be taken and people will come to know that how this robotics and automation, it is helping in every way. Though cost is high, but its results are good.
So you are trying to just make people aware about what is happening in the real
Yes, sir.
time
Yes,
scenario.
sir. Yes, sir.
So I think had it been more good, like if you could have like shown something like what is exactly happening inside, like with some scientific logic, because everyone knows like a robot is doing something, everyone knows like some big
Yes, sir.
machine, some non-invasive technology, non-invasive liquid biopsy, this, that, blah, 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 So I think
Yeah.
I think what I like more interesting is here you have used automation to automate this PPT, because you have used a lot of
Yes.
AI based tool for generating. That is the
Yes,
most
sir.
interesting
Yes.
figures you have generated. But anyway, I think you could have shown some basic basic architecture, like what people have used, so that you can make us more knowledgeable about those kind of things. But overall, good. It's a good content that what you have shown us.
Presentation actually.
Yeah. Thank you.
Okay, sir.
Yeah. Thanks.
Ma'am,
Okay,
actually, the
I'll.
thing is that, ma'am, next time when you go for a forum,
Yes, sir.
try to do a background study. Okay, for example, you have mentioned about automation in radiology.
Yes, sir.
It is nothing but the use of AI ML in
Yes, yes.
segregating or getting the result. So you could have added some more results actually. Any one paper you would have taken.
Yes,
So you
sir.
would have one or two papers or something like around 10 to 15 papers you could have taken, and you could have summarized that. Getting my point? There are
Yes,
several
sir.
exoskeletal.
Actually, sir,
There are
I
several
did work,
exoskeletal
but
supports are there.
sir, actually, I can't show so many slides. It will become. That's why I deleted many matter.
No, you don't have to show so many slides. Even some people, they show only one slide and they talk. Have you seen Sundar Pichai, what he is showing? He's showing only one slide,
Yes,
and but he
yes,
talks
sir.
so like 1 hour, and people are
Yes, sir.
amazed with by. So one thing I would like to emphasize with all those who are present here, like being whether you are beginner or you are at middle level or you are at the advanced career stage, just try to ask yourself why you are presenting this and who is your audience, and try to think about what new you are going to talk with as a presenter, because
Okay, sir.
everyone's time is precious. I am just trying to
Yeah,
tell
yeah.
every student, those who are presenting here or even who are faculty, because don't try to don't try to be repetitive, try to show something
Yes,
new, something interesting. Otherwise, we can just Google. We have ChatGPT, we have Perplexity, blah blah blah. So many things. We can just type one thing. We can use what there are many softwares now. So at least try to show something interesting in a PPT.
Okay.
Okay, thank you.
Okay.
Yeah.
Okay.
Thank you, ma'am.
Thank you.
Thank you. We can go ahead with next presentation.
Our next presenter is Preeti Dongre. Please start with your presentation.
Ma'am, I have shared my screen. Is it visible?
Yes, it is visible. Please start. Thank you.
Yeah.
Ma'am, actually stick with a brief intro, then result and discussion, because we are lack of time.
Okay, sir. Yeah, fine, sir. My name is Preeti Dongre, and I'm doing PhD in Madhyanchal Professional University. And topic of my presentation is NADS-based essential oil extraction from waste pills of citrus sinensis. It is for yield enhancement with acetylcholinesterase inhibitory activity. So the in introduction, the essential oils, these are obtained from medicinal and aromatic plants, and these possesses a unique flavor, fragrance, and basically these are in volatile nature. We have used some green techniques, sustainable emerging techniques. In that we have used natural deputatic solvents. These are the solvents which offers advantages like it increased extraction efficiency, solubility of the product. It gives a increased bioactivity, stability, and shelf life of the bioactive compound also increases by using this NADES as a co-solvent. The sample of my research work is a citrus sinensis. It is a orange, and as we are in the local area, that is Nagpur, it is top in production as well as an economy. So the need of work is here. So we are working on that sample. The waste pills of citrus sinensis, while eating, the waste pills are thrown away just on adjacent land, and it causes unnecessary environmental load, and as well as BOD increases. So to give the value to that pills in pharmaceutical, cosmeceutical, and nutraceutical sectors, we have chosen this sample. So objective of my work is to extract the high yield essential oil by using the natural deputatic solvents, that is choline chloride and lactic acid. These two, choline chloride and lactic acid, are selected just they are used preferably amongst other NADES, and these choline chloride, it acts as a hydrogen bond acceptor, and lactic acid is hydrogen bond donor. And these solvents offers a great advantage than the others NADES. Another objective is to study the composition and concentration of extracted oil by GCMS. And finally, acetylcholine esterase inhibition was checked of the extracted oil was checked. This activity was chosen, acetylcholine esterase inhibitory activity, just to see the effect of oil on cognitive disorders, as this enzyme work on the cognitive diseases like Alzheimer's and Parkinson's. The methodology is we have used the choline chloride and lactic acid. Choline chloride is hydrogen bond acceptor, and lactic acid is hydrogen bond donor. We have used 3 different ratios, that is 1:1, 1:2, and 1:3. These are based on a molar ratio, and we chosen this concentration based on the previously published work. They worked on the another sample, so we are chosen for our sample. So pills were powdered, and microwave assisted technology was used to extract the oil. And firstly, these samples, these solvents, NADES, we pre-treated it. We made these we made these solvents by heating it heating it at 80 degrees Celsius, a clear liquid form. And these clear NADES liquid solution we use for the pre-treatment of the with sample, that is citrus sinensis pill. So pre-treatment was done again in microwave, and then hydrodistillation was carried out by adding 250 ml of water, and we got the oil that is essential oil. Further acetylcholine esterase activity was carried out. So these are the ratios, that is 1:1 and 1:2, 1:3. The transparent colorless liquid we got by heating it on in a beaker. We have taken on the basis of molar ratio and heated at 80 degrees Celsius. We received a transparent colorless liquid. I have explained this, so I'll move ahead. Then GCMS and GC and GCMS analysis was carried out. So this sample analysis was carried out at CMAP CSIR Lucknow. They have given these conditions. On these conditions they have worked and given me the results. Acetylcholine esterase enzyme inhibition assay was carried out by using previously published paper was followed, and in that the absorbance was taken. The sample was prepared in different dilutions, and finally absorbance was taken at 5 nanometer, and galantam and hydrobromide was used as a standard. So percent inhibition was calculated. These are moving to the result and discussion. So MAHD, that is MAHD is a water treated sample. N1 MAHD, that is used ratio of 1:1, and 2 MAHD used ratio of 1:3. and 1:2, and N3 use the ratio of 1:3 of choline chloride and lactic acid. So we have observed that the yield was increased from 2.2% to 19.4%, where the molecules of lactic acid are high. We got the highest yield, best yield. In appearance, oil also vary. That is, with water, it is a golden yellow, and with these NADS, we got light yellow colored liquid. Some physicochemical characteristics was carried out, like RF, specific gravity, solubility, pH, and total phenolic content. Slight changes in the results was found. GCMS analysis. In GCMS analysis, total 19 compounds was obtained with water treated sample, higher than the NADS treated sample. In NADS treated sample, we got 16 compounds. But the advantage of NADS treated sample, we got the highest percent area, that is with N3MAHD, and limonene was the major monoterpenoid that is found in N1MAHD, that is 89.7%. Percent inhibition, acetylcholinesterase inhibition activity, the percent inhibition was shown, and it increased with the increase in concentration. So best activity was obtained at 100 microgram per ml, and N3MAHD sample, that is the ratio of compound is 1:3. We got the best result compared to galantamine hydrobromide. In conclusion, these NADES, these are the green solvents, and these solvents boosted the yield of the oil. If industries, that is in local area industries working on the where the abundant sample is present, they can extract the high yield oil in very less amount of sample. Best yield was obtained with 1:3 ratio. In GCMS analysis, variation in concentration and chemical composition obtained. So with specific composition and concentration, the pharmacological outcomes, specific pharmacological outcomes can be targeted. Insignificant inhibition of SCHE enzyme was obtained in assay. These enzyme worked in the Alzheimer's disease. Citrosinensis, either alone or with the combination of other drugs, it can assist the treatment of Alzheimer's disease. This oil also can work as in the formulation of natural insecticide. Lastly, we use the green solvents and waste pills, so environmental load can be reduced. It can generate the income to the local people in the areas where the sample is abundant, like Nagpur and all over wherever the cultivation is. Okay, fine. Thank you. This work is supported by Department of Science and Technology under WOSB scheme. So I'm thankful to them for providing the funding. These are the references. Thank you.
Thank you for your presentation. We can now begin the Q&A session.
Yeah, hi Preeti. I think nice presentation. So I would like to ask why did you choose to do this study? So this has already been done by many people. I think is that the method is new, the NADES something?
Yeah, these are the emerging solvents nowadays, and these are providing advantages than the conventional methods. So with the advanced technology we used here, and we are trying to pass these technologies to our local area, as we are from Nagpur. So basically working on that, and this is a part of my. Yes,
It's
sir.
fine. I think let's talk the scientific thing. You have in the title you have mentioned about any NADS based essential oil extraction of waste citrus sinensis peels for yield enhancement. So is that the new thing, the NADS? That is what you are trying to establish here. So first of all, you have written yield enhancement. Are you increasing the yield, or are you enhancing the acetylcholinesterase inhibition activity?
I have increased the yield, sir. Basically, with water, it is 2.2%, but
Yield.
with the help with this solvent, by using this solvent, the yield is increased. And
Yield is increased.
yeah,
Okay. And also your activity is also enhanced, like acetylcholinesterase activity
yeah, with the oil
compared to what?
extracted by NADS, we got the
Uh,
enhanced activity also.
I think you have to reframe your title a little. It's confusing, you know. So basically, you are achieving two things. One is high yield, another
Yes,
is enhanced acetylcholinesterase activity due
yeah,
to this some new some base you have used is a
method.
new method NADS based. Okay.
Yes.
Yeah, I think something new you have done. Okay, thank you.
Okay. Thank you, sir.
Okay, all the best. Okay, fine.
Thank you so much, sir.
Is there any question from the audience side? If there are nothing, then we can move ahead with next presentation.
Thank you for sharing the presentation. Our next presenter is Adi Sharma. Adi Sharma, are you there?
Hello,
Yes, please share screen.
just give me a second.
Miss Preeti, please remove your screen.
You can go ahead, Adi Sharma. You can go ahead
Yes, sir.
with your presentation.
Is it visible? Hello.
Yes, go ahead. Yes, go ahead.
Good afternoon, everyone. My name is Adi Sharma. I'm a undergraduate student at Deenbandhu Choturam University of Science and Technology. And the topic of my paper today is recent development in non-thermal plasma sterilization techniques. Without any further ado, let's get started. The agenda of this presentation is to highlight the advantages of non-thermal plasma over the traditional sterilization method, demonstrating how they are superior in almost every aspect. Along the way, I will also discuss the various advancements in non-thermal plasma technology. We will also briefly cover the mechanism of action for non-thermal plasma, and lastly, I will elaborate on its limitations. So, what is non-thermal plasma? For those of you who are unaware, non-thermal plasma, also commonly known as cold plasma, is a type of quasi-neutral ionized gas in a non-equilibrium state, meaning that the electron temperature is significantly higher than that of the heavier particles like atoms and ions. In contrast, in hot plasma, all the particles are in thermal equilibrium. Many of you may wonder what is its relevance in sterilization. The unique property of cold plasma to generate reactive species, particularly reactive oxygen and nitrogen species. These reactive species facilitate various cellular reaction that inactivates microbes, which we will discuss in detail in the later sections. The non-thermal plasma, often used as a broad term encompassing various types of cold plasma, as you can see here. Just give me a second. As you can see here, there are various types of cold plasma. For example, microwave cold plasma, DBD. DBD stands for dielectric bed discharge, and various other types of plasmas. These plasma can be classified based on the relationship between the electron temperature and the gas temperature, as illustrated in the graph presented here. As you can see, the electron temperature for the cold plasma is much higher and the gas temperature is relatively low. For example, comparatively compared to the flame, which is also a type of plasma. They are much lower, and the electron density is higher, making the gas suitable for at near room temperature, making it a more suitable option for biomedical application. Now let's discuss the traditional sterilization technique. Firstly, the most commonly used methods is heat sterilization. As we can further classify these into those two subclasses. The first being moist heat sterilization, also commonly known as autoclaving. This method is very cost effective and does not produce any residue, although it cannot be used for heat sensitive items and is also limited to non-moisture sensitive items. For example, some polymers, some biofilms. And the other subclass of heat sterilization is dry heat sterilization, which uses very high temperature to eliminate microbes. This can be used for moisture sensitive items. It is again not suitable for high 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 temperature sensitive material, high moisture sensitive material. The second most common sterilization method, which is used on a large scale in the industry, is ethylene oxide, or short for ETO. The ETO is vaporized at relatively low temperature, around 40 degrees Celsius. This gas can treat various complex geometries, like oscilloscopes, bronchoscopes, which are packed post sterilization in a special material called tieback, which facilitates more effective sterilization. This type of sterilization is ideal for sensitive materials, but it has a major downside. It is highly toxic and carcinogenic in nature and has a long aeration time. Aeration as in the residue remains for a longer duration comparatively to other sterilization, necessitating a strict safety regulation. The third most commonly used techniques is radiation sterilization, which can be further subdivided into two classes. The first being UV sterilization. No, it is a non-thermal method that can be used for heat sensitive material and leaves no residue. However, it has a low penetration power and can only be used for surface sterilization, and it causes UV degradation, which can further affect the molecular makeup of materials, especially when used on living tissue. The other subclass of radiation-based sterilization is gamma sterilization, which solves the penetration problem of the UV sterilization, making it suitable for bulk sterilization. However, the problem of radiation damage to the material still exists, and even in living tissue, making it subject to strict regulations, and it also requires very expensive equipment to perform. Now in the slides, now that we have a basic understanding.
Adi, speed up. Huh?
Now that we have a basic understanding of how the traditional methods work and their advantages and disadvantages, we will examine the main mechanism of action of non-thermal plasma. The purple region here represents the cold plasma generated by the device. The primary mechanism of the primary mechanism of microbial inactivation through the generation of reactive species. Here are a few of the reactive species generated by non-thermal plasma. Although there are two less commonly discussed mechanisms. The first one being direct energy transfer through higher temperature electrons and the UV radiation. They contribute very little to the inactivation of microbes directly, especially the UV radiation, because the UV radiation and these are generated in a very minor amounts. The main pathway for microbial inactivation are as follows. Firstly, the reactive species, particularly reactive oxygen nitrogen species, including hydroxyl ions, hydrogen peroxide, and superoxide anions, causes oxidative stress in microbial cells. This stress arises from an imbalance between reactive oxygen nitrogen species produced and the cell's detoxification capabilities, resulting in damage to lipids, protein, and nucleic acids, ultimately leading to cell death. Another pathway is through membrane degradation, where the ROS stands for reactive oxygen species, are also also modify the protein, also facilitates pre-peroxidation of lipids, and the hydroxyl radicals also extract hydrogen atoms from the unsaturated fatty acid in the membrane, causing a chain reaction that compromises the membrane integrity, leading to leakage of crucial cellular organelle. Another pathway for microbial interaction is the um, um, the modification of modification of proteins and nucleic acid in nucleic acid. The reactive species causes the denaturing of proteins and also modifies the DNA, causing loss of enzymatic activity and causing mutations or strand breaks, hindering the replication and transcription. Lastly, the presence of reactive oxygen nitrogen species significantly alters the oxidation and reduction potential of a solution. For instance, the production of hydrogen peroxide and the other oxidants increases the oxidation reduction potential, indicating a more oxidative environment that further facilitates the aforementioned reactions. One more interesting thing.
Adi, it is better if you summarize. It is better you go on with summarization part because we lack of time. Whatever you wish to tell, you just go on with summarization.
So can I have 2 minutes to explain this diagram?
Yeah, I think it's better to sum up, just go to summarize, just what you want to say.
Cold plasma.
We have so many people.
Cold plasma also produces plasma activated water, which is nothing but water treated with cold plasma, and it generates reactive oxygen nitrogen species in the water, as demonstrated here by this diagram. And the properties of the cold plasma also vary depending on the fed gas and the power configuration. This is the OES of the aforementioned plasma. The plasma device used was known as APPJ, which stands for atmospheric pressure plasma jet, which is the type of plasma device, cold plasma device, and these OES these graphs indicate various OES spectra of plasma jet at different flow rates and at different fed gas concentration. For example, the upper graphs indicate spectra of only air, and the below spectra indicate the OES spectra of fed gas, where the composition is argon plus oxygen, argon plus air. The recent advancement in non-thermal plasma technology are one of the major advancement is the dibireactor discharge, where the
I hope we got your point, man. It is better we will open up for what you call a question and answer session. Okay, fine. Adi?
Yeah, I think you better just sum up. What is your point? Just go to this last slide. What's the conclusion of your talk? I think you have made a in detail review kind of literature, So
Yes.
I think I would urge everyone to be very restrictive. Time is precious. We can just restrict 4 to 5 minutes or 3 to 4 minutes. Everyone. So can you go to last slide, Adi? Yeah.
Yes, sir.
So summarize either with the slide or you by the words. You just summarize what you wish to tell.
Is the advantage of non-thermal plasma technology over traditional methods is
Uh-huh.
that it produces no chemical residue and is optimal for non-thermal operations, and is a very effective and is a very cost-effective method for sterilization for even bulk or point sterilization, and depending on the configuration of the plasma torch, and very eco-friendly and sustainable for the environment. And the
Fine.
Yeah, we understood. Yeah, thank you. So
Thank
These are
you.
the
what is
Thank you.
what is the
I'm
most
open to
what
any
is the
question.
most latest? Yeah, what is the most latest advanced version of this non-thermal
So
the
the
instrument?
most latest is the mentioned. Actually, I am working on a plasma jet. The plasma jet, the APPJ.
Now you are not
Atmospheric
getting the
pressure.
point actually. You are not getting the point. Sir was asking about what is the latest advancement, the current one.
Yes, sir. This jet was currently developed in 2020 and is further being researched on. For example, I'm currently conducting a research to use only air to sterilize and treat the samples.
Is it atmospheric air?
Yes, sir.
So what will be the special application of for this one? Like,
So, for example,
why
in the
will
sorry.
why for what application will you use this jet? Like, for example, if I want to sterilize the normal bench top for my biomedical application, we can simply use the some lamp, or for cell culture we can use UV visible. So what is the this non-thermal something you are saying? Why
So,
we
for
are using
example,
this?
you can autoclave or UV the endoscopes, and the I mentioned about the ETO. The ETO is a very toxic substance, and the plasma is here to the cold plasma is here to replace that technology.
I see. Okay.
Okay, thank you, Adi. We can go ahead with the next presentation.
Yeah, next one. Thank you.
The next presenter is Yashika Yadav, and everyone, like Abhimanyu sir suggested, will be keeping a timer. Everyone, please complete your presentation in approx 5 minutes. Yes, our next presenter is Yashika Yadav. Are you there?
Yeah, wait a minute.
Yeah.
Can you see it?
Yes, it is visible.
Okay. So I'm Yashika Yadav. I'm from Weldtech University. I'm in final year, and I did the study on inflammatory property of Heliocarpus oblongus against formalin-induced inflammation in Vista rats. So basically, I did the exposure to various organic compounds, including a number of environmental pollutants and drugs, and caused cellular damage like through metabolic activation of those compounds to highly reactive substances. And there are highly reactive molecules derived from metabolic of oxygen. So basically, my study is about the inflammation, and the antioxidant capacity of the medical plant, which I use. The antioxidant capacity of the medical plant and herb has been linked in vivo protection from oxidative stress in numerous studies that I did and read in about the research papers. But It has been seen and associated with anti-inflammatory capacities. And for this reason, the present involves the evaluation of oxidant by using DPPH, radical scavenging assay, which I used as a method to find out the inflammation and what happens when I use my plant, uh, Eliocarpus oblongus. So there are two types of inflammation, acute and chronic. As you all know, acute is basically short-term one and is pretty harmful for the injured tissues. It can cause redness, increase heat, swelling, pain, etc. And the chronic inflammation is a prolonged inflammation. The materials and method which I used were the DD the DDPH radical scavenging assay, and the materials I used was the plant and the animal, which was I choose the plant as Eliocarpus oblongus and the animal as Vista rats. And with that, so the Vista albino rats were used in this experiment. They were housed in polypropylene cages under standard conditions of temperature 23 degrees Celsius and humidity 55 for 12 hours in both light and dark cycle, fed with standard and pellet water. Experiment we did in like 5 groups. The first group was for normal control rats. The second was for formalin induced rats, which is the first photo, and we induced 0.1 ml of 2% formalin in it. And the second one, the second photo is from the group 3, in which we use standard drug indomethacin.
Okay, okay.
And
Okay, Ashika, the thing is that the images are not clear enough to come to a conclusion. Okay. You just need to concentrate on it. You are final year BTech student, right?
the what?
You are final year, you said. You are final year BTech student.
Yes, sir.
Just concentrate on that. Huh? Okay. And from the audience side, if anyone is having doubt, they can ask. It is about what you call it is about classification of inflammation. Is there anything? Abhimanyu sir?
Yeah, I think the research topic is good, but I think the way of presentation, I think you are presenting a poster to us, it seems. And also, this work has already been explored a lot. The only new thing what I can say is the species of this, the species.
The
I
plant
think
species, right?
the plant species, yeah, that is what is new here. I think you could have at least emphasized why you have used this as an anti-inflammatory, because the other species in the same category has already been explored a lot. Yeah, so nothing new.
Fine. I hope Yashika, you will work hard. Okay, you have time, so you just concentrate on that and you work further.
Yeah.
Okay.
Okay, sir.
Yeah.
Okay.
Good work.
Yeah,
Thank you, sir.
I have put one link. I have put one link for everyone who is interested in doing research. There is it's a very good it's a free website from Government of India. So I endorse this one because this is a very good freely available from Government of India, and it's conducted by ICMR, National Institute of Epidemiology. So you can go through. I think they have almost 23 days course. It's freely available. If you want to get certificate, you can just pay 1,000 rupees and write. It's a proctored exam also you have to give. But that's a very good start for those who are interested, Yeah, thank you.
Okay, fine. We can go ahead with the next presentation.
Thank you for sharing the presentation. The next presenter is Roshni Khetan. Please start with your presentation. Roshni Khetan, are you there?
Yes, ma'am. Hello.
Yes.
My PPT is visible or not?
Yes, it is visible. Also, please try to complete the presentation in 5 minutes.
Okay, sure, ma'am. Hello, good afternoon to all of you. I am Roshni Khetan. I am presenting my research work, which is mitochondrial dysfunction related to the ultrafine particulate matter in GC1 SPD cell line. As we all know, ambient air pollution become a serious health problem in which particulate matter play a major contributor in it. Particulate matter divided into three on the basis of their size, that is coarse particle, fine particle, ultra particle. We propose the study of mouse spermatogonia epithelial cells, that is GC1 SPD cell line, in which we check how the mitochondrial nucleus crosstalk take place and which causes the male infertility. For that, we perform evaluation of DNA damage. Also, we check the relative gene expression of cell cycle regulatory protein and mitochondrial oxidative stress. Objective of my impairment of mitochondrial nuclear crosstalk in GC1 regulated pro-cytokines in the exposure of ultrafine particulate matter. To check the aberrant regulation, we also check the cell cycle regulatory protein as well. This is my research work graphical abstract in which I show how male in reproductive toxicity particulate matter. My major focus on the ultrafine particulate matter. In particulate matter intake cross our plasma membrane, and then further there are so many NF-kappa B mediated pro-inflammatory cytokines response take place, and which further causes in a nuclear DNA damage as well as mitochondrial DNA damage. In my study, I take around 3 numbers of untreated cells and 3 numbers of cells, in which we show, and we also examine study on the different time interval, that is 24 hours, 72 hours. This is a microscopic image of when cells will uptake the ultrafine particulate matter. Am I audible?
Yes,
Hello?
go ahead.
Okay. My work element include the different 3 major parameters, that is mitochondrial nuclear signature, protein biomarker, and mitochondrial signature. For the mitonuclear signature, we check the mitochondrial DNA copy number. This is my workflow of my work. And for mtDNA copy number, we check for nuclear mitochondrial copy number is basically comparison between nuclear DNA and mitochondrial DNA. For nuclear DNA, we took a beta-actin as a reference gene, and for mitochondrial DNA, we took ND1 genes, and we check and we see the difference between the controlled and ultrafine particulate matter. There is a less amount of mtDNA copy number in ultrafine particulate matter. So it means there is a damage in mitochondrial DNA as well. So for this, we further analyze how mitochondrial DNA is affected or not. For this, we examine whole mitochondrial DNA genome on the basis of conventional PCR techniques, in which we design 9 different primers in different fragments which cover all the mitochondrial DNA, and we perform the conventional PCR and run gel electrophoresis. This is agarwal gel images in which we show that there are some fragments like F3, F6, F8 fragment are absent as compared to control one. In control, there is F3 and F5 bands were absent. F3, F5, and F8 are majorly for the complex 1 and 5 regions. So for this, we cross-check this result by using the DNA methylation level. For this, we check D-loop region. We perform the we first isolate DNA and then we treat BAM-H1 treatment. As we know, the mtDNA is circular in nature, so we linearize the mtDNA and then we bicycle conversion take place, in which if there is a methylated cytosines are present, which is remain cytosine, and if there is a absence of methylation, then cytosine converted into uracil, and then we perform PCR techniques, and here the results of the PCR techniques. After that, DNA methylation, we check the mitochondrial gene expression. This is a mitochondrial gene expression images in which we perform COX-1 gene, ND6, ATP6, ATPase 8. In all of these jail images show there is a deregulation expression of the gene. So further, it shows that there is a damage of the mitochondrial DNA as well. Further, we check for the mitochondrial nuclear crosstalk. We check the NF-kappa B and inflammatory cytokines, that is IL-6 and TNF-alpha. For this, we also isolate these RNA samples and we perform RT-PCR and we check by using the real-time PCR analysis. Next, we also perform DNA methyl transferase, which is basically involved for the DNA methylation. This is enzyme which is involved in the DNA methylation in case, sorry. Yeah. Yeah. This is a image. This is a real-time image in which we shows how the threshold level of the different time of the samples or gene, and this is the UFPM, that is ultrafine particulate matter exposed the expression, and we showed on the basis of their graph on the real-time PCR. Then we perform TET12. This is a gene which is responsible for the nuclear methylation. And we also perform the cell cycle regulatory protein by using the Western blot analysis, in which we check the different kinds of regulatory protein, that is 21, 53, CD1 and CD2.
Ms. Roshan,
Further,
please
we
try to
also
wind it up. Your time has been exceeded.
my this is my last slide. And so my result conclude there is we see altered expression in mtDNA copy number and fusion as well. And further, for this disturbance, we check the DNMT state ones and also show that there is a change in the COX-1 and D6, which suggests that there is a damage which causes the ultrafine particulate matter, which causes the male infertility, and that is my group where I thanks to Sage University, which provide the platform for the PhD work, and ICM are needed for supporting my research work. Thank you so much, sir.
Yeah, nice and impressive presentation. Can you go to the first slide? Yeah.
Yeah, sure.
I think will not take much time. Yeah.
First
Yeah,
slide.
I think
That is
go to the object, the graphical abstract itself. Yeah.
Yeah,
The
sure.
graphical. Yeah.
Okay. Yeah.
I think what I understood is you are trying to show the role of mitochondrial dysfunction in the reproductive health, isn't it? So what sort of
sir.
and you have chosen this SPG something, some cell line, isn't it?
Yes, the
Is
GC1
what sort of
cell line,
what is that cell line is? What is that cell line?
Sir, actually, this is mouse spermatogonial cell line. Actually, we always talk about the female infertility, but due to some regions, male also infertile in nature due to exposure of several things like smoking and all. And
so you are talking about
yeah,
it's fine. So you are talking. Sorry to interrupt. So you are trying to show that there is a cytokine storm, like after the, and what sort of model you have used in the in vitro, like how did you, yeah, I mean, what kind
Actually,
of experiment you did?
yeah, I performed this, for example, I show my this slide. Yeah. This is a mouse spermatograph. Yeah, it's
UFPM.
epithelial
This is you have used ultrafine particulate matter.
Yes, sir.
So
So
is
we
this commercially available or not?
Yes, sir, yes, sir, yes, sir. This is commercially available. We use this is from Sigma Albrecht company, and we
Okay.
treated our samples by different time interval or different concentration. That is, we usually
Yeah, I think
perform
it's
different
fine. Yeah,
concentration.
it's fine. It's fine. I think just answer what I'm asking. So I think
Okay, sorry.
the scale
Yeah.
bars are missing in this, first slide. Can you go next slide, next slide.
Study design
Go
after study design.
Just go next slide. Yeah, go next slide. Yeah, go to the result. Yeah, here you have shown a lot of these graphs. I think this should be all these data. No, go back. Yeah, all these graphs should be backed with some what kind of normalization you have done. So here, for example, on the y-axis, you should show all those amplification plot, as well as you should also show
This is
what kind of
on
normalization. Yeah, what sort of normalization you have done? Have you used beta actin, beta tubulin, gap DH? What did you use in
I
this?
use gap DS, sir.
Okay. Yeah. Okay. Thank you.
Yeah.
I think it needs more discussion. Okay. Thank you.
Yeah. So this is a very vast topic. Thank you so much, sir.
Okay. Thanks for your presentation. We'll go with next presentation.
Thank you for your presentation. The next presenter is Mariam Maroof. Please start with your presentation.
Roshni, you can. Okay.
Roshni, you can stop sharing the screen.
Hello. Hello.
Yes.
I hope I'm audible.
Yes, you're audible. Please start sharing the screen.
I've shared it. Is it visible?
Yes, it is visible. Mariam,
Okay,
make sure that you go on with your objective, followed by methodology if needed, or else go ahead with your result and discussion.
Okay, sure. Okay.
Bye.
Shall I start?
Yes.
Okay, so good afternoon to one and all. This is Mariam Maroof. I'm a research scholar from MNIT Lab at Prayagraj. And my work is based on utilizing FEA to design a trapezoid shaped splint for traumatized tooth mobility. So here on the left, you can see the contents, which I'll be discussing further. And on the right is the flowchart that is followed that actually explains the simulation process carried out to optimize and finalize the dental splint design based on the concept of uniform stress distribution and minimum force deflection behavior. So just a little intro that what is a tooth mobility? Tooth mobility means the tooth is displaced from its socket, and there is a certain degree of mobility that is allowed, which is around 0.2 mm, which is required for healing of the tooth or to undertake certain occlusal and masticatory forces. It is known as physiological tooth mobility, but increase in the degree of this mobility beyond 0.2 mm is highly undesirable. And major causes of it are occlusal trauma or dental trauma, and it is like mainly prevalent in teenagers and young adults. So there is like if the mobility is beyond a certain range, it can even lead to loss of a permanent healthy tooth, because the tooth is not damaged, it's just that its attachment with its socket is lost. So there is a non-invasive aesthetic and effective practice in restorative dentistry, which is known as dental splint. It is a device, as you can see in the figure. It is used to attach the unhealthy tooth with its adjacent healthy tooths through its structural attachment, and thereby transferring load with whatever is occurring there in the unhealthy tooth. So there are a variety of existing dental splints, but the major drawback of these splints are that they are made of conventional material. That is, they cannot allow the teeth the physiological mobility, which we need actually, so that there is, along with its attachment, there is healing of the tooth. So the objective, as I've discussed, is to use FEA to find a new design of superelastic nitinol-based dental splint material. So first, what we have done, we have taken a nitinol film of 0.2 mm thickness, and we have obtained the experimental curve using cyclic tensile test. It is shown in blue curve, and from that we have extracted the material parameters as given in the table. These parameters are further used to generate the simulation curve for the same tensile test. And as we can see, there is a very good computational fit between the simulated curve and the experimental curve. Now, these parameters will be further utilized in ANSYS Workbench to obtain the stress distribution and force reflection behavior of the proposed splint. So figure A here shows the control splint that we have taken into account, because for the in order to verify whether our new design is behaving well or not as per the requirement, we have compared its data, the obtained results, with this control one. So figure B actually shows the concept that is taken into account to like get a new design of the splint. So it is based on the shape of the maxillary incisor. It came out to be isosceles trapezoid, and we have constrained few parameters like DA, which is the inter-aperture distance, as 3 mm, and the total height, which is around 50% of the crown of the incisor. So based on this, 3 parameters we will be varying, which is the arm width, outer curvature, and height of this splint, and then we'll be finalizing 1 or 2 of these splints further. So this is just the meshing and the boundary conditions that were used in ANSYS Workbench. And first we have done the superelasticity tensile test. We have loaded this single motif of this proposed splint and then unloaded and assessed the stress distribution. So as you can see in this figure, C is the control splint, and if you see the peak stress that is generated in the control splint is in larger region near the inner and outer curvatures. Compared to this, although there is higher value present for the peak stress in the proposed splint, but it is at a very small region, and all the other parts of this proposed splint show better and more homogeneous stress distribution as compared to the control splint. One more thing to note down here is that these splints will be attached through the resin adhesive. So based on that, if we see the C diagram, which is of the control splint, the high stress present near the inner curvature will actually lead to more deformation of the splint when adhesive will be attached, whereas better results will be obtained if our proposed splint is taken. Then the same concept is present over here for the wider arm of these splints. Then the second superelasticity test we have done by taking into account 3-point bend test as per ISO 15841. And first we have done the deflection at the arms, and then we have deflected the splint at the joints. And for the unloading curve, we have taken into account one parameter known as ratio of variance, which actually relates the deactivation curve with the midpoint force level. So it gives, this parameter will actually give how these splints will behave with respect to one another. So here the graph is shown for the arm and joint deflection of the narrow arm splint. So as we can see, the proposed splint TS1 and TS2, they have low force deflection value, whereas in figure B, almost similar values shown for all the splints when compared with the control splint. Also, in table, we can see that the ROV value is similar for all the splint, be it control splint or the proposed splint, with the same value of midpoint force level. And same is for the joint deflection. This means that all these splints during unloading will give the same amount of force, and they will behave in a similar manner. So there's not much variation that we all have obtained for the narrow arm splint as compared to the control splint. But if we look for the wider arm splint, then the proposed splints have very low force level value, peak force level value, as compared to the control splint, with TS4 splint giving the least force value of all at the end of deflection. Similarly, when joint will be deflected, the proposed splint will have lower force level values as compared to the control splint. Also, TS3 and TS4 has shown the ratio of variance higher as compared to the control splint for the same level of unloading force. This means that more level deactivation curve will be there, indicating that almost uniform force will be
Sorry
provided.
to interrupt you, Mariam, but the time has been exceeded. Please find a
Okay,
way.
I'll just conclude it. Then one new test we have done, it is actually bending the splint along the arch of the human maxilla. So we have taken data from the literature and we have obtained the data for like we have standardized this maxillary arch dimension, and then the bending is done for the splint along this arch. So as we can see here, the TS4 splint shows lower value as compared to the control splint, up to 7.9 mm of deflection along the maxillary arch. And if we look at the normal stress generation, then up to 4 mm of deflection, the material has shown a linear increase in stress. That is mainly because of elastic deformation of the splint, and it is in the austenite region. But as we deflect it further, the austenite to martensite phase starts, that is, it enters into the subelastic range. But still, all these values are near to each other only. And here is the stress distribution on these splints. And if you see, large area of peak stress generation is there for the control splint, whereas the proposed trauma splint show lower region of peak stress distribution, and it is near to the austenite to martensite finish stress. That is, it has not undergone plastic deformation. We can rebend it and reuse it again. So the conclusion is that we have proposed a novel design of superelastic nitinol-based trauma splint with the shape of an isosceles trapezoid that resembles the shape of the tooth crown. And we have obtained homogeneous stress distribution for it as compared to the control splint. Force levels are also lower. And it is recommended to bend near the arm instead of joint while attaching the splint to the maxillary teeth. And these are the finalized splint design dimensions. These are the references. Thank you.
Mariam.
Yes, sir.
It is good. You have shown quite a good resource. So
Thank you, sir.
you have taken traditional material and you have changed the design, right? Simple.
Yes, sir.
Okay, fine. It is good. Go ahead with the work. And nothing. If audience from the any questions from the audience.
I think, yeah, I think nice content and also presentation. Yeah. Have you thought about filing the patent for your design?
Yes, sir.
I
Yes,
think
sir.
you should file your design, but
We have filed the
you should
patent.
you should think about also finding some angel investor for this if it is working.
Real time.
Yeah.
Actually, you need to go ahead with a real time application.
Yes, sir. Like
It does not
future work,
require any what you call any ethical clearance. The
And
art.
also,
like we're working
yeah.
on the maxillary model and doing the same, like verifying it with the experimental results.
Because you are going to use traditional material, it is
Yes, sir.
already well established. Only the thing is that you have changed the structure. So structurally, you need to verify it. And the thing is that you have quite loopholes, like quite condition, like you need to fix the end which is desirable, right?
Sir, actually, this design is better than the controlled splint, that rhomboid shape, because that has the, if you cut it and attach it to the teeth, it has protruding ends, but our design won't have that. And so it will be like more comfortable to the patient.
That's good. You need to think about that. Okay.
Okay, sir.
Fine. Fine. Then we can go ahead with the next
Yeah.
presentation.
Okay. Thank you,
One
sir.
more. Hello.
Sure, sir.
Yeah, one more point I would like to say that I think you are from MNIT, isn't it?
Yes, sir.
I think you can also talk to your this supervisor about writing some that's big. There is a big grant from DBT. You know, DBT is DBT or DST. They're providing 50 lakhs rupees for
DBT big.
DBT. Yeah, something like that. So you can talk to your supervisor, and there might be some entrepreneurship cell might be there in your university.
Okay.
So you
Sure,
can first of all you can file a patent. You know, design patent. Yeah, thank you.
Okay.
Nice work. Yeah, bye.
Sir, actually, we have started the filing process.
Yeah, get the file done and then simultaneously ask for some angel investor. I can get some investor for you also.
Okay, sure.
Let me
Thank you
know.
so much,
Yeah,
sir.
and
Thank you, everyone.
Okay.
Thank you for sharing.
Thank you.
The next presenter is Shushmita. Please start sharing your screen.
Okay, give me a second. Is it visible?
Yes, it is visible, but you're not audible properly.
Is it audible now?
Yes, you are now.
But your slides, we could not able to see your slides.
Oh, okay. Hold on 1 minute. Can you now?
No, it's not visible.
Give me a second. Is it visible now?
Yes, it is visible now. Please start.
Unstable. Okay, okay. Good afternoon. I'm Sushmita and my partner Aishwarya. We're from Biomedical University, 4th years. And the topic of research is development of an edible Vitex-derived nanoparticle, a novel therapeutic approach for the treatment of rheumatoid arthritis. Am I audible?
Yes, you are.
Hello?
Yes, you are audible.
Am I audible?
Yes, go ahead. Go ahead.
Yes.
Am I audible?
Sushmita, you are audible. Go ahead with your presentation.
Okay. Um, okay. So the topic is development of edible Vitex-derived nanoparticle, a novel therapeutic approach.
Since she left, you can go ahead with next presentation. If she comes, we can accommodate her later.
There must be some network issue. Let's start with the next part, presenter, Devyansil. Are you there? Devyansil, are you there? Let's just wait for 1 minute to let Roshni rejoin, Sushmita rejoin, then we'll start. Sushmita, are you there?
Hello?
You are having some network problem.
I'm so sorry.
Your voice is cracking a bit.
Nothing to worry.
Yeah,
Go
I'm
ahead with
there.
your
Can you
presentation.
hear me?
Yes, I can hear you now, but your voice is cracking a bit in the middle.
Yeah, I'm so sorry about it.
It's okay. Start with the presentation.
So, as my internet is a little bit unstable. I'm so sorry. Hello? Okay.
You can call up the next person.
Yes, sir. Divyansal, are you there?
Yes, ma'am.
Please start with your presentation.
Yes, ma'am. Sure.
Put a message to Sushma, ask her to wait further.
Yes, sir.
Is it visible, ma'am?
Yes, it is visible. Please start with the presentation.
Good morning, everyone. Good afternoon, everyone. My name is Divyansal, and I am a Master of Pharmacy student in Quality Assurance Department from ISF College of Pharmacy. So today I am going to present my poster on the topic exploring metal organic frameworks for advanced pharmaceutical and biomedical applications. Metal organic frameworks are advanced biomaterials which are mainly characterized by very high porosity and surface area. These biomaterials are built with two different components mainly. As the name suggests, first building block is metals. For example, zinc, copper, iron, cobalt, which provides a range of coordination geometries and electronic properties based on their charge. And the second building block is
Devian, sorry to disturb you. It is related to you have done a review of literature, right?
yes, yes.
Can you summarize it? Then it is like if it is like a research, we would have gone into deep. Can you summarize it? What you have found? What is about what?
Sir, I have discussed about this particular drug delivery system, and there are many other applications in medical field. For example, diagnosis of disease and other therapeutic uh, uh, therapeutic uses of metal organic frameworks. How they are synthesized, how their structure can be modified. All this I have explained here.
Okay. Okay. Have you looked in the aspects of toxicity? So how functionally it is being made or
So they
something?
actually they are for like other novel drug delivery systems are available. The like organic nanoparticles, they are toxic, but the main advantage of metal organic frameworks are that they are not toxic. There is one only limitation of metal organic frameworks is about their stability, which can be improved by modifying their structure and uh, like like one I have mentioned here is post-synthetic modification by various techniques like bioconjugation, coordinative transformation, encapsulation, and hybridization. We can improve their stability as well.
Okay, fine. Actually, it is like MOF. Fine.
Yes, yes.
Okay, okay, man. Okay, is there anything, Abhimanyu sir, whether you need to ask something? Because
Sorry, sir.
I think
Abhimanyu,
it's fine. Yeah, it's fine. Yeah.
because it
Thank
is
you.
more towards literature review, so we
Yeah.
can end up the session if she's
Yeah. Thank you.
uh,
Yeah.
so
I think he can just present like 1 minute at least. He
one
has
minute.
made some. Yeah, it's fine.
Okay, sir. Sir, mainly, as I have said, MOFs are biomaterial-based drug delivery system, and they are synthesized using methods like sonochemical synthesis, conventional solution method, diffusion synthesis, ionothermal process method, etc. Then we can modify their structure. Like we can compare these biomaterials with sponges. Like sponges has very minute pores within them, and but their structure is not uniform. But here we can program them in a coordinated way so that we can obtain a very uniform structured pores and cages within the metal organic frameworks, within which we can incorporate our drug or any biomolecule for the treatment purpose and other medical purposes. And there are many, as drug delivery researches have been performed that I have mentioned in table 1, where ibuprofen drug was encapsulated, and fluorouracil have been encapsulated, and many others. Further, they have also importance in point of care diagnosis, and further, yes, that's it.
Okay, fine. All the best for your features, huh?
Thank you, sir.
We can go ahead with the next presentation, the last one, right?
Hello.
Yes,
Am I audible?
Yes, yes, go ahead.
Okay, I'm so sorry for the unstable internet connection.
Not a problem. It is not your problem. Okay.
Okay, thank you. Is it visible?
Yes, it's visible. Please try to wind it up in 5 minutes.
Yeah, okay. So I'll start from the top. Good afternoon, everyone. I'm Sushmita and my partner Aishwarya. Today we'll be presenting our research on the development of edible Vitex-derived nanoparticles as a novel therapeutic approach for the treatment of rheumatoid arthritis. So the introduction is rheumatoid arthritis is a chronic defibrillating disease requiring novel therapeutic approach. So we are using edible nanoparticles derived from Vitex negundo. It's a plant which offers a promising natural delivery system for the treatment. So as we all know, rheumatoid arthritis is a chronic autoimmune disease which causes inflammation and pain in the joints. So current treatments for rheumatoid arthritis, including anti-inflammatory drugs, which can have serious side effects, are not always effective. So we are using nanotechnology, which is nanoparticles derived from natural plant sources. Next, I'll give it to my partner, Aishwarya.
So our research focuses on Vitex negunda, which is a plant known for its anti-inflammatory and antioxidant properties. So we are using, so from that we are synthesizing nanoparticles. So our objectives are to explore the potential of Vitex-derived nanoparticles in reducing chronic inflammation and preventing rheumatoid arthritis, and to examine the safety and efficacy of Vitex-derived nanoparticles through in vitro and in vivo studies, and to explore the potential as a natural and less effective and less toxic alternative to current RA treatments. So we used PEG 6000, which is polyethylene glycol, which helped us to purify and stabilize the nanoparticles, which prevents the aggregation.
Next, the purification of the Vitex-derived nanoparticle, we're using techniques like the size and the stability, zeta potential. And finally, we tested for the anti-inflammatory effects of, Finally, we tested the anti-inflammatory effects of VDNP using rheumatoid arthritis mouse models. And we measured the levels of pro-inflammatory cytokines, particularly TNF, which is tumor necrosis factor alpha, which is the key for inflammation in arthritis.
So as we see in the picture, the VNDPs at an average size of approximately 230 nanometer with a stable stable zeta negative potential, indicating that they were well dispersed and unlikely to aggregate. And in the in vivo studies, these VDNPs significantly as reduced TNF alpha levels in the RA mouse models, indicating a strong anti-inflammatory effect. It also enhances the survival of the B cells, which is very crucial for immune regulation, and it prevents further joint damage in these models.
And for the results, the VDNPs average 230 nanometers in size and a negative zeta potential indicating stability. VDNPs significantly reduce pro-inflammatory cytokines and improve joint conditions in arthritis models. It also enhanced B cell survival and decreased chronic inflammation were observed. Importantly, our toxicity studies showed that VDNPs were non-toxic at the doses tested with no adverse effects observed in the treatment in the mouse. We gave like 0.3 milligram every day for 7 days, and we noticed the graph. It's given there. Yes, sir.
Fine, you're done, right?
Yes, sir.
Okay. So,
So what is no? Yeah, go ahead, sir. Yeah.
same thing. What is the novelty in your work?
Sir,
So you have written, first of all, you should not write novel in your title by yourself. You should not hype up
okay.
your own thing,
Okay,
it's
okay.
it's the reviewer who will decide whether it is novel or not.
Okay, sir.
You should never
Yes,
write novel, most of the I mean people, a lot of people are writing in their paper novel therapeutic way. Anyway, so tell me, this vtex derived nanoparticle, it has already been published. Many people, I just checked roughly, and it's been published by many people. So what is new here? And also, you have just shown the zeta potential about the dispersivity and all these things.
yes, sir.
Size
And
is very
then
huge. It is like 230 nanometer.
Yes, sir.
30
Yes, sir.
nanometer, yeah.
It is very huge actually.
It's huge.
Okay.
It's like yeah, generally because these are synthetic nanoparticles. So synthetic nanoparticles, generally I think you can control the size and all. But anyway, I think overall this
And
research
you
can be
have used
more.
ultra. You have not used any this thing, right? Sonigation method.
So we did, sir.
You did sonigation.
No, sir, we did not use sonification, but we did ultra centrifugation methods.
I centrifugate is to collect the nanoparticle, but
Yes, sir.
sonigation you would have done.
Sir, we are still carrying out because we're in fourth year. That's why, sir.
Okay, fine.
Yes, sir.
Abhimanyu, sir, please.
Yeah, I think you have to. You guys are in doing PhD with this?
We are interested in doing it, sir.
What do you mean
No,
by
no, they
fourth
are
year?
final year BTech students.
Final
Oh,
year.
BTech. Oh, okay, okay. Yeah, I think I would urge you to delve more, little bit deep about
Okay.
this kind of
Yes,
thing,
sir. Sure,
and
sir.
try to read one of the best paper in this field,
Hmm.
and don't just go with your whoever is your supervisor, or just try to ask question, okay, and check what other people, some of the best scientists are doing in this field, and
Sure,
try
sir.
to ask question,
Yes, sir.
then you can think about something new, and
Yeah,
don't
okay.
hype up by yourself. It's not
Yeah.
novel, okay?
Sorry, sir. Yes, sir.
Yeah. No, it's fine, just question yourself.
Yes, sir.
Yeah, thank you.
Thank you so much.
Thank you.
All the best. Huh? Bye.
So this was the last presentation of this session, and we will continue after the lunch. I request to everyone to switch on their camera for a group photograph. Everyone, please switch on your cameras. Yes, thank you. I'll be taking the photograph now.
Okay, thanks for everything. Okay.
Yes.
Thank you, Abhimanyu sir and Yunesh sir, for accepting our invitation
Yeah,
and
thank you.
providing the constructive feedback to the oral presenter. And over to Khushi.
I would like to express a sincere appreciation to our esteemed session chairs and evaluators for their engaging and insightful contribution and for their constructive feedback. Thank you so much, Yunesh sir and Abhimanyu sir.
Yeah, it was great listening to all those enthusiastic researchers, and yeah, don't take any of the comments personally, but yeah, try to enhance the quality. Okay, thank you.
The comments was purely to enhance your work, whatever you are doing. Okay, fine. All the best for everyone.
Also, thank you to all our presenters for sharing their insights and invaluable contribution. Also, we'll be having our next session from 2 p.m. after the lunch break. Please rejoin the meeting.
Thank you.